We have been preparing for this event for a while, and finally it come true. And we have all our friends all over from the globe here, and we're going to start on time. A whole setup. We have those two screens here, and the speakers later. We're here, and we have to look at it here. If you have a need for a binocular, please let me know if we're going to have one. But anyway, so. This is our great pleasure to welcome healthcare professionals, researchers, educators, and industry leaders from around the globe. And we are honored to bring together such a diverse community of experts. We're united by a shared commitment to advance medical knowledge, improving our patient care, and fostering the innovation in healthcare, especially in the field of diabetic foot management, this very challenging field that we have. So as we're beginning from today, I would like to introduce Dr. Ridgway, who is the Dean of University of South Dakota, to have a welcome note for everybody. Dr. Ridgway.
Well, thank you, Alan, and good morning. Distinguished colleagues, honored guests, industry sponsors, trainees, and friends. On behalf of the University of South Dakota Sanford School of Medicine, Sanford Health, and the organizing committee, it is my real pleasure to welcome you to the Rushmore Diabetic Foot Reconstruction Forum. We are especially honored to host an international faculty representing expertise from across the globe. The collective knowledge gathered at this room reflects decades of innovation, research, surgical advancement, wound care expertise, vascular intervention, rehabilitation science, and limb preservation. Thank you for traveling around the world to share your experience and, importantly, to advance the care of our patients. Today, we gather around a challenge that transcends geography, healthcare systems, and economic boundaries: the prevention of diabetic foot complications and limb loss. While our practices may differ, our mission is universal: to preserve mobility, maintain independence, improve quality of life, and, importantly, to save limbs whenever possible. So, why are we here? 400 million people worldwide have diabetes. 6% of all hospital discharges are due to diabetic foot complications. 70% of leg amputations are for people with diabetes. And need I remind you, the mortality rate of those who require amputation that are diabetic is higher than many common cancers that we deal with today. 25% of patients with diabetes have foot ulcers, 85% of diabetic foot amputations, 85% can be avoided. The first sign of diabetes is a wound that does not heal or heal slowly. 1 in every 6 diabetics will develop a foot ulcer in their lifetime, and those who have diabetes are 25 times more likely to lose a leg than those who do not have this condition. The diabetic foot remains one of the most complex problems in modern medicine. It is not merely a wound problem. It is not a vascular problem. It is not solely an orthopedic, podiatric, infectious disease, endocrinology, or rehabilitation problem. It's all of these simultaneously. Every diabetic foot ulcer represents a convergence of neuropathy, ischemia, infection, metabolic disease, biomechanics, and yes, social determinants of health and healthcare access. The complexity of these patients demands something equally sophisticated in response: a coordinated, multidisciplinary team, which is what we have assembled here today. No single specialty owns the diabetic foot. The diabetic foot belongs to the team. So let's talk about the rural healthcare reality. As we meet here in the Mount Rushmore state, it is particularly appropriate to recognize the unique healthcare challenges that are faced by rural communities throughout the United States and across the world. And yes, here in South Dakota. 64 of the 66 counties here in South Dakota are designated as rural or frontier, with dozens classified as medically underserved areas or health profession shortage areas. These shortages are heavily concentrated in the central and the western parts of South Dakota. Minnehaha and Lincoln counties, where you are gathered here today, is the one exception where we don't face these shortages. So what are the factors that contribute to this shortage? Geographic isolation, travel time, access to a provider of any type, 2 to 3 hours or more. Weather, ability to get to a healthcare provider. Workforce recruitment, recruiting people. And I would argue today, everyone, that technology is tremendous, but if we don't have the people there to begin the process and help them to access all the expertise that we have, what have we gained? And getting these people to small rural clinics and critical access hospitals is increasingly difficult. If they have the expertise behind them, telemedicine, abilities to recognize early what to do, I have learned from our trainees, they are more willing to go to these areas and serve. And then there's the socioeconomic and insurance barriers. Many people in South Dakota are uninsured, and the infrastructure, the healthcare infrastructure in many of these areas is just not where it needs to be. South Dakota is home to several of the poorest counties nationwide, primarily located within or adjacent to our Native American reservations. These counties consistently rank among the bottom 10 out of 3,100 U.S. counties for both high poverty rates and low medium income. Poverty rate comparisons, just to give you an idea. Nationally, it's about 10%. In Oglala Lakota County in western South Dakota, 52 to 57%. Todd County, western South Dakota, 49%. Millette, Corson, and Ziebach counties, 38 to 46%. Nearly 1 in 5 Americans live in a rural area, yet access to specialty care remains very limited. Rural populations tend to be older, you know this. They have higher rates of chronic disease, they face longer travel distances, and often they encounter significant barriers to specialty services. Rural hospitals continue to face financial pressures, workforce shortages, and threats of closure. And this creates substantial gaps in advanced diabetic foot care. For many patients living in rural America, the nearest vascular surgeon could be hours away. The nearest infectious disease specialist may be unavailable. Advanced wound care centers are inaccessible. Reconstructive foot and ankle expertise may exist only in distant metropolitan areas. And yet, diabetes does not respect geography. Peripheral arterial disease does not respect county lines. Charcot neuroarthropathy develops whether a patient lives in New York City, Sioux Falls, rural South Dakota, or a farming community halfway across the world. So as specialists, we must ask ourselves a critical question. How do we deliver world-class limb preservation to patients who live far from world-class medical centers? This challenge is not unique to South Dakota and the United States. Colleagues from every continent understand this same reality. Whether the barrier is distance, workforce shortages, infrastructure limitations, or healthcare financing, the need is the same. Bringing multidisciplinary expertise to the patient rather than expecting the patient to navigate a very fragmented system. Here at the University of South Dakota, Sanford School of Medicine, our mission is to train high-quality physicians and have a curriculum that encourages them to return to South Dakota and particularly to health profession shortage areas. We hear a lot of talk about rural healthcare and what it means. But you know what you have to do? You go and talk to the providers that are in these communities. Then you learn what we really need. We've got all this wonderful technology, incredible, but we've got to have the people to be able to give access to these patients so that they can enter the healthcare system and have the ability to receive this expertise that we have here and online today. So what is the power of multidisciplinary care? I've said the future of diabetic foot care is not defined by any particular specialty. It is defined by specialties that become connected, what all of you are doing here today. The most successful limb preservation programs will integrate endocrinology, podiatry, orthopedic foot and ankle surgery, plastic and reproductive surgery, vascular surgery, infectious disease, wound care specialists, physical medicine and rehabilitation, orthotics, nursing, physical therapy, primary care. Diabetes is rampant in some of these counties that I talked to you about. And we have to recognize it if we're going to do something about it. Each member contributes a critical piece of the solution. The endocrinologist will optimize metabolic control. Infectious disease manages the complex infections. The vascular surgeon restores perfusion. The reconstructive surgeon restores function and stability. The rehab team restores mobility. And together, I would argue, they restore hope. Our greatest advances in limb salvage have not emerged from isolated excellence. They have emerged from coordinated excellence. One of the most exciting aspects of this forum is the diversity of perspectives represented here. Throughout this meeting, we're going to hear different approaches to Charcot reconstruction, limb salvage algorithms, complex wound management, vascular intervention strategies, surgical fixation techniques, offloading technologies, rehabilitation protocols, emerging technologies and innovation. No surgery has solved every challenge. No healthcare system has discovered the perfect model, but every system has developed solutions that are worth sharing. Our goal over the coming days is not to merely present data. I think one of the real beauties of something like this is that we learn from one another. We challenge assumptions. We refine our approaches to build relationships that continue long after this meeting concludes, because every advance shared here has the potential to improve outcomes of patients thousands of miles away. The future of diabetic foot reconstruction and limb preservation will be shaped by collaboration. It will involve telemedicine and remote monitoring. It will involve artificial intelligence and predictive analytics. It will involve new biologics, advanced imaging, and evolving fixation technologies. But I'm coming back to a theme here. Most importantly, it involves you. It involves the people. That is still going to be critical in our endeavors. People that work together across disciplines, across institutions, countries, and continents. The patient with a threatened limb does not care which specialty receives the credit. They care that the team works, including our learners, our medical students, residents, health sciences students, and others, which Dr. Yan has also graciously assembled, is crucial. We have to begin there and develop these individuals to see what matters and to work and learn the multidisciplinary approach to cutting-edge problems. So in closing, as we begin this forum, I encourage all of us to approach these next days with curiosity, with humility, and a willingness to learn from one another. May this meeting spark new ideas, new collaborations, and new friendships. May it strengthen our commitment to multidisciplinary care. And may it ultimately help us achieve our shared goal fewer amputations, better function, improved quality of life, and better outcomes for patients living with diabetes around the world. On behalf of the University of South Dakota, I thank you for joining us. Welcome to the Rushmore Diabetic Foot Reconstruction Forum, and welcome to an extraordinary opportunity to advance the science and art of multidisciplinary diabetic foot care. Enjoy the next 2.5 days. Thank you very much.
All right. I cannot wait to tell the story and how this has started and how the structure of this conference and some housekeeping issues before we started all the our fascinating top world leaders are here. We literally bring the world to us in Sioux Falls. So as Dr. Ridgway has mentioned, so this Sioux Falls, that's in the middle of the Midwest, and it used to be the frontier of the United States, where the United States, America, spirit of America is. So the reason we named it a Mount Rushmore is that's the icon, not only for South Dakota, but also the icon for the United States. But some of the audiences, some of the people ask me, the actual Mount Rushmore is 5 hours away. It's so it's on the other side of the state. But anyway. I'm telling them, okay, there are all international bunch of foreigners who are going to be here. They do not know until here. Then I'm going to tell them. I'm just joking, but so it is. But this is the icon. This is where American spirit is. This is where Midwest is, and we have a special program called Frontier and Rural Medicine. So we have outreach, and this is perfect for this setup for a multidisciplinary group, and we will find our style, find our foundations, and find our model in the Midwest. So this is the giant behind all the Sanford name. This is Mr. Danny Sanford, and he's a philanthropist, and he donated all the funding for setting up the whole system. And this whole building you are here, and this is a research building. And we have such a capacity to do basic science research along with the clinical research here. And a little bit of history of Sioux Falls. Actually, Sioux Falls was the very first FDA-approved total ankle. This ankle is called agility. And Dr. Frank Alvine, he retired, and his son is in practice. I think that Dr. Alvine will be here at some point. So they are still revise their agility, and hopefully they're there. So I'm not overwhelmed with agility revision. But this is the legacy and legendary from Sioux Falls. In 1980s, 1990s, people are flowing from here learning how to do total ankles. So this is the history here. So the story behind this is we set it up, H&H Foundation. Those are my parents' name. Unfortunately, my mom passed away during the COVID, but her wishes to carry on the healthcare, and he is as a son of my mom. So we established this foundation in honor of her wishes, and this is the foundation behind this forum. And also we have great support from USD and Sanford Research, and that's the birth of Mount Rushmore. Last year we started online. We have 500 attendees, and we concentrated on one of the specific areas, reconstruction, and especially TTT surgery. And so we have participating nations this year with from all corners of the world, and with all the experts in this field. And here is our platinum sponsor. We really appreciate Orthofix, Violex, Paragon, and Depth Health as our gold sponsors. And we have our silver sponsors, well-known names in the industry, and we have our bronze sponsors. So please visit all those booths. We have a beautiful setup over there in between each talks, and we have breaks. Please visit them. They are the one behind all those. Without them, this is not going to happen. So we're also proudly partnering with VuMedi, and pretty much if you're a surgeon or a physician, you will know it. And OrthoBullets is all trainees using the worldwide. So we were broadcasting on those two platforms. And also, I forgot to mention Foot Innovative, and we partner with Foot Innovative also. And we will have our guest speakers, keynote speakers. Let me briefly introduce. And we have packed with all the top leaders in this field in the 2.5 days. And we have our keynote speakers, Dr. Michael Edmonds, the giant gentleman and very humble, as I met with him in King's College. And we have our King's College's group all here. And also Dr. Busui, Dr. Rodika Busui, she was the 2023 president of ADA Science and Medicine. So she will be our keynote speaker. And here is our King's College group, and we'll enjoy your talks and learning from and experiences from you guys. We have distinguished guest speakers from Italy, Elizarov surgery. That's Dr. Kirienko was the foot and ankle chief for Dr. Elizarov as the starting. And we have our Asian surgeons, and Dr. Hua is personally here. He started very first TTT surgery 26 or 30 years ago. And let's learn from his experiences. And this is fascinating talks he has. And we have Singaporean surgeons joining us too. Here is our guest, distinguished guest speakers from Chile, and Dr. Fuentes and Dr. Bastias, and they'll share their experiences in this. And we have our European colleagues here, who is Dr. Bus is the man behind all the new guidelines from 2023, and Dr. Armin Kohler, he operates probably almost 0.5% of those patients in Germany. So, and we have our domestic leading experts, and we enjoyed this show. This is going to be like, we bring the world to us here, and really appreciate everybody is like, I somehow persuade my friends all coming here, and people asking are Sioux Falls, and Sioux Falls is on a bucket list for most of the people who visit, and they haven't been in their life. So I have a book, a gift book, it's called The Bucket List, and I will send it to you guys. But make sure, be aware, this is not a scam. This is truly what's happening here. So I try to convince people to say Allen Yin and Sioux Falls. That sounds, but it is real. So this is the architecture. What are we going to do those 3 days? The first day we have a didactic, and the second day, Friday morning, is didactic surgical procedure, and first day multidisciplinary. And then we have, uniquely, we have 3 labs. One lab is gearing towards the mid-level non-surgical labs, which is TC, total contact cast, and ABCs, essential of diabetic care. And Dr. Lavery and Dr. Adam Nichols kind of leading that labs. And I encourage every people to sign up in the front. So we have a hands-on experiences, great for the students, great for non-surgical or even the surgical, I leave it up to my podiatry colleagues to do excellent jobs. Otherwise, I do not know how to perform my task. Then we have another 2 cadaver labs. One is Elizarov, led by our esteemed Italian surgeon groups, and our Chilean surgeons will help. And we have the labs of TTT, which is transverse transport of tibia. Has been, it's relatively new in the West or in United States. But anyway, it has been running almost 30 years in China, in Russia, and we have the best speakers here to share the experiences here. So also we're announcing the establishment of sibling societies. We established International Society of TTT in order to foster and gathering all the bright minds, and we're gonna increase our awareness, also doing research and coordinated study. And also we have a sibling society of Elizarov for the ankle. We're planning to do international basic courses, advanced courses around the globe in the following years. So housekeeping is make sure we visit, and we have faculty dinners tomorrow night in downtown across the Canopy Hotel. And also tonight we have a reception right across this research center. It's a barn, and we have a reception there. Make sure everybody is mingled. And so this purpose of this is really the first in-person meeting. I want to raise the awareness, and the concept and awareness is really important. I don't have to repeat on how extensive this problem is worldwide. And those are the number that will be repeated on each talks. And there is no need for me to repeat it too much. But here are 40 million people, and some status there's like over 40 million people worldwide having this problem. And you're thinking about like 15% of them have ulcers, and then that's a huge number. So there is saying, Chinese old saying, that you're looking at a leopard through a bamboo tube. So you do not see the whole thing. And our care is really fragmented as everywhere we go. And also, this is from my Italian colleagues. So when they presented this cases in Italy, in Pisa, so there's an annual meeting in Pisa. So this is the same idea. We're looking at the problems like blind people feeling the elephant. Nobody has the whole picture. And also, it is a mythbuster since I started traveling around and learning what's going on. So I thought, we were always taught that amputation, people after amputation, they feel like so much better. That's what we taught as an orthopedic surgeon, orthopedic resident. But look at what happens. So this is one of the major papers. People fearing amputation more than death. This is not the only thing. This is like really important slide. I want to imprint it in your mind. So you look at it compared to the major cancers. So if you have major amputation, BKA, AKA, they were not far away from the cancer, even worse than that. And this is shocking, quite enlightenment movement that changes in my mind. I thought so we do not have adequate education on that. And the treatment is also costly, not only deadly. So this is a deadly conditions. And the new concept of foot attack, we will see throughout this talks, and we will have patients mention that. And the MDT, the multiple disciplinary care, is the way, has been proven working really well. So, and also be aware of the international guidelines. And we set it up our center. We're going to follow that guidelines and collect the data. And working with the international centers like King's College groups, Italian groups, and any groups that we were established with. And we have surgeons who started TTT, and this is one of our highlights of our. So our purpose is, we established a rural model here, international exchange, and also we established a protocol, which is following the standard of the care. So that's our purpose. So on the segue of this, let me introduce our very first keynote speaker, Dr. Edmonds, Dr. Michael Edmonds. Such a gentleman, humble, but giant behind all MDT. So his work in early 1980s, he established the very first MDT in the world and started in King's College. And because of his work in the landmark of a European St. Vincent Declaration, the Europe societies has set it up a reduction of amputation by 50% in 5 years. That's what, because of his and his group, our esteemed guests are all here. And let's listen to what Dr. Michael Edmonds will give. Okay, all right.
Good morning, ladies and gentlemen. It is a great pleasure to talk to you today about our experience in combating diabetic foot disease. These are my conflicts. So in this talk, I'm going to first describe the genesis of the MDT foot model, and then its 3 phases of development over 45 years. The initial phase of the diabetic foot clinic from 1981 to 84, the expansion and developments of its role from 84 to 2014, and the evolution to a regional diabetic foot day unit from 2014 to 2026. The genesis of the MDT model arose from an appreciation and understanding of the natural history of the diabetic foot, which is time-dependent and aggressive, and in which time is tissue. Empirically, we recognize 6 scenarios or phenotypes of the diabetic foot. All these scenarios were vulnerable to the rapid development of gangrene and thus the risk of amputation. In the neuropathic foot, there was the neuropathic ulcerated foot and the Charcot foot. In the ischemic foot, there was the neuroischemic foot, the critically ischemic foot, the acutely ischemic foot, and the renal ischemic foot. Now, each of these scenarios have their own natural history, which could be depicted by the simple staging system, going from normal, high risk, tissue loss, threatened, and gangrene. And I would describe the natural history of these, starting with the neuropathic foot, which develops ulceration, infection, and gangrene, and the Charcot foot, deformity, ulceration, infection, and gangrene. The neuroischemic foot, ulceration, infection, gangrene. The critically ischemic foot, tissue ischemia, gangrene. And the acutely ischemic foot, cyanosis, mottling, and gangrene. And the renal ischemic foot, digital necrosis going to forefoot gangrene. Now, all these natural histories can be described as foot attacks, similar to the heart attacks and brain attacks, leading to loss of tissue. In these three scenarios are shown here on the left. The main driver to the gangrene is infection, although neuropathy plays an important predisposing role. In the three scenarios to the right, which I have previously showed you, the main driver to gangrene is ischemia. So the basis of the genesis of the MD foot T model was the rapid progression to necrosis, and thus it was important to form an MD foot team with appropriate expertise and skills, which when combined would combat this aggressive history and provide input, continuity, and oversight in the care of the diabetic foot patient, and develop also a physical base to accommodate the MDT foot model. So in the 7th of May, 1981, we started our multidisciplinary diabetic foot clinic, as shown here on the left, with podiatrist, nurse, orthotist, diabetologist, and support from orthopedic and vascular surgeons. And the following weekend, we had an open day, invited people to come and seek more information on the diabetic foot clinic. Now, in this 3-year initial phase, the important aspects of management were intensive podiatry, focused antibiotic treatment, specially constructed insoles and shoes, and revascularization, both endovascular and open bypass. And healing was achieved in 80% of neuropathic ulcers and 72% of ischemic ulcers. And this resulted in a 50% reduction in major amputations, a reduction in both neuropathic and ischemic amputations. And this was published in a paper called Improved Survival of the Diabetic Foot, the Role of a Specialized Foot Clinic. And it was important to show that we could reduce the number of major amputations, and that amputation was not inevitable in the diabetic foot. And the St. Vincent Declaration, which was made by a group of WHO, International Diabetes Federation, European governments, and patient organizations in 1989, took our figure in their recommendations to improve diabetic care for citizens and to reduce by 50% the rate of limb amputations, as well as other recommendations regarding reducing new blindness and end-stage renal failure. So let me go on now to the expansion development of the role in the 30 years from 84 to 2014. And within this, we should be aware of the context that there was a massive increase in the number of patients being diagnosed with type 2 diabetes. And there were more ischemic feet than neuropathic feet. So in comparison, from 81 to 84, the initial phase, we saw a total of 239 diabetic foot patients, 148 neuropathic, and 91 ischemic. And in an audit period from 2000 for a 6-week period, there were 340 diabetic foot patients, 160 neuropaths, and more 180 ischemic patients. So in this expansion row, we went forward with four improvements in the service: the rapid access emergency service, total contact casting, Charcot foot reconstruction, and distal revascularization. So we established an open access service to see emergency cases on the same day or within 24 hours, taking urgent referrals from all healthcare professionals, general practitioners, community nurses, community podiatrists, and also referrals from patients. And in an audit of that service in 1987, in 107 patients, 83% had skin and soft tissue lesions, 14% had acute nail and joint lesions, and 3% rest pain. And the outcome, 86 were treated as outpatients with a 90% healing rate, and 21 were treated as an inpatients with an 86% healing rate. We needed to improve our offloading and introduce total contact casts. And we went to see Dr. Paul Brand. He had been a medical missionary treating leprosy patients in India. And in 86, he was a specialist in the U.S. Leprosy Hospital in Carver, Louisiana, treating leprosy patients and diabetes patients. And we learned from him the gold standard treatment, the total contact cast for treating neuropathic ulcers. In this period also, we introduced the program of Charcot foot reconstruction led by Professor Manu, whom you will hear from later. In 2015, we reported the operative outcomes of 20 patients with Charcot neuropathy, all presented with severe deformities, and 15 had chronic ulceration. All underwent correction of deformities of the ankle and hindfoot using retrograde intramedullary nail arthrodesis, and 7 patients also underwent simultaneously midfoot infusion using boats, locking plates, or a combination. And at a mean follow-up of 26 months, limb salvage was achieved in all patients, ulcer healing in 12 out of 15, independent mobilization was regained by all but one, and a failure of fixation only occurred in 1 patient due to a broken nail and required revision surgery. We also introduced our King's distal bypass outcome, led by our surgeons Hisham Rashid and Hani Slim. And the latter reported 230 distal bypasses in 2011, 65% in diabetes, 30% in chronic renal failure. 30-day mortality was 1.7%. 1-year mortality was 12.2% because of the comorbidities, but the limb survival was 96.6%, and the 1-year major amputation low. So high limb survival rate and low amputation rate. And these innovations helped us to continue reduce the amputation rate. Looking at the percentage of our clinic patients, it was reduced to a very low rate of 0.2% of the clinic. And finally, I just want to talk about the evolution to a regional diabetic foot day unit from 2014 to 2026. In this time, we continued with the reconstruction of the complex Charcot foot, with now marked collaboration between orthopedic, vascular, and plastic surgeons, backed up by the wound healing expertise of podiatrists and nurses of the clinic. Also, we expanded the revascularization of the ischemic foot and introduced a new approach to distal ultradistal bypass, the minor approach, which stands for minimally invasive novel open revascularization. And I'll come to that in a few seconds. We also introduced a virtual national diabetic foot MDT and extended the physical base to facilitating minor surgery in the clinic. This case description illustrates superbly the collaboration between surgical specialties. A very deformed foot in an ischemic leg needed a FEMPOT bypass initially, then the orthopedic reconstruction, then a below ankle, below knee bypass, and then plastic surgery with negative pressure and skin graft to end up with a plantar grade healed foot. Now, the minor approach the minimally invasive novel open revascularization had three elements: endoscopic vein harvesting, shortest possible length of vein bypass, and limited incisions to minimize tissue damage. And Hanny Slim reported 73 patients, 63% with diabetes, who underwent NT1 total infrainguinal or infrabrachial minor bypasses. He was also revascularizing hands at the time. So, but the majority were for chronic limb-threatening ischemia, and 9% for popliteal aneurysm. Bypasses were to the popliteal artery, 23%, tibial arteries, 40%, pedal or palmar arteries for 37%. And the primary and secondary patency rates at 1 year were 70% and 80% respectively. Limb salvage and amputation-free survival rates at 18 months were 95% and 88% respectively. And the 1 year mortality rate was reduced compared with the previous 12% to 4.9% because the incisions were very minimal and patients were mobilized much more quickly and got home quickly. We also introduced the virtual National Orthopedic Diabetic Foot, MDT. The aim was to ensure patients and treating clinicians had access to specialist diabetic foot MD care, regardless of whether they were based in the UK. So this was from Monday, 8:30 to 9:30. Clinicians could log in by appointment by video to discuss their patients with the King's Foot team, which then offered advice on care. And in a service review from October 22 to September 24, with 242 consultations from 86 patients over 37 external sources, as well as internal referrals. And there were outside referrals from all over the country. And the MDT outcome was that in 136 cases, advice was given and patients continued on their local management. In 6 cases, they were invited to rediscuss their case after advice and further treatment. And in 90 cases, we brought patients to be reviewed and seen in the King's Diabetic Foot MDT clinic. At this time also, the team was evolving and there was also an evolving physical base, a full weekly program that maximized interaction between disciplines and facilitated joint clinics and provided continuity of care. So our multidisciplinary foot team now comprises podiatrists, surgeons, diabetologists, specialist nurse, orthotists, radiologists, microbiologists, and psychologists, focused physically in the diabetic foot clinic, which acts as a control center for hospital community, allows open access, and also acts as an admission and follow-up center. In 2020, under the care of Dr. Chris Manu, the clinic was refurbished with 7 treatment chairs, 2 side rooms, and 2 minor procedure theaters, which allowed us to carry out surgical procedures in the unit, wound debridement under LA, tendon balancing procedures, toe amputations, skin grafting, and bone biopsies. And all these were carried out within the context of the weekly timetable for the Diabetic Foot Clinic. So at 8:30 on Monday, there was the virtual national MDT. At 9 o'clock every day, the daily morning team huddle. And then throughout the day, we were receptive of emergency walk-ins and also MDT clinics between podiatry and diabetology continued throughout the week. On Monday, there were joint clinics between the orthopedic and MDT clinic, a ward round and MDT clinic. On Tuesday, the vascular surgeons came with a joint vascular ward round and MDT clinic. On Wednesday, again, joint orthopedic MDT clinic, Charcot clinic, a vascular radiology MDM, a microbiology MDM, and continuing with the Charcot MDT clinic. And on Thursday, a joint vascular orthopedic plastic MDT. And on Friday, of note, a renal microbiology MDM. So in conclusion, although the diabetic foot is indeed complex, limb loss is not inevitable. And with the MDT model of care, which is rapidly available and driven by surgeon, podiatrist, physician, with input from all MDT members. Most amputations can be prevented. They are not inevitable, and most feet served. Thank you very much.
We are honored to have Dr. Edmonds joining us from London, and he can entertain some questions for us. If anyone has a question, throw your hand up and we'll bring the microphone over to you.
Yes. Well, this is such an honor to have Dr. Edmond to give us his views. And this is the giant. He is the man behind all this. He dedicated all his career in teaching and research and clinical care. So any audiences or questions? Yes, please.
Dr. Edmonds, can you hear me?
Yeah. Can you hear me?
Yes, I can.
Okay.
Thank you for that. Quick question. I saw that you're including a psychologist for part of your multidisciplinary team. Are they doing like group meetings with the amputees, or what exactly are they doing for your patients?
Well, we've had an attachment of a psychologist, and we were trying to, well, first of all, look for patients with obvious psychological, psychiatric problems, because many of our patients are anxious and depressed and facing major surgery. And the psychologist helped on a one-to-one basis to prepare those patients for that operation. We also had noticed that patients who, despite all our efforts, don't do all that well and may come to amputation, often have a combination of background issues, such as poor socioeconomic circumstances. We're in a very sort of poor, deprived area of London. And also they have mental health problems. So we don't actually not really progress to groups at the moment, but more to, as it were, pick out and detect the patient at risk in whom who are not doing well, and that the psychological issues are really very important. And that's been our approach so far. But I agree with you. Picking out patients and helping them on a group basis may be, in the end, more efficient and helpful to our patients.
We have time for one more question.
Dr. Edmonds, Vinod Panchbhavi from Texas, USA. Thank you for your great talk. Just wanted to touch upon the preventive aspect of these things, you see. So I still see patients, who come from our primary care doctors, from other specialties, who have been treating, say, for example, charcot as an infection or cellulitis.
Right.
And I do see there is a lack of awareness, there is lack of education, not only in our doctors, but also patients. So what can we do to improve the education and the preventive aspects, to prevent patients, first of all, from getting this problem, and second of all, if they come to the physicians, ensuring that they get the proper care from get-go. For example, if you have an MRI scan, it shows a signal change in the whole fifth metatarsal, and then the first thing surgeons tend to do is take the whole fifth metatarsal off, and that sets off a precedence to an amputation. So what all can we do to educate, to prevent on the starting side of these things?
Yeah.
Well, I absolutely agree with you. And it was only this week that we saw patients in clinic who had developed a swollen foot and ankle in the October of that year, and was treated with several courses of antibiotics, and really didn't get to an orthopedic person until the March. I think it's basically a system approach. We have regular visits and from medical students and podiatry students to our clinic. So we hope to, as it were, show them and educate them on the issues of the Charcot-Foot. In my sort of 5-minute sort of initial teaching, I say there are 3 causes of a red foot, red swollen foot: the infected foot, the Charcot-Foot, and the ischemic foot, which is actually red but cold. And so really trying to get the message over right at the beginning of their career. And also, I think now there is a move in UK to get all the 9 so-called tests that people should have annually done at one time and at one sitting, and to encourage education for that at that time. But it's a really big problem, and I can't say that we've conquered it at the present. And you bring up an important issue.
Okay. All right. Thank you very much. We are so honored to have you, Professor Edmonds. It was due to like a time differences. I really appreciate you taking your time and answer live questions. Thank you.
Thank you.
And
Thank you very much.
all right. Thank you for your time. All right. So, all right. So we move along, and we have Dr. Chris Manu, so who is diabetologist. So first time I saw that term, I even have a hard time twist my terms to pronounce it. So we do not have that term in the United States. But then last year I led my group and I witnessed what's going on and how active he is in the MDT clinic. I truly start to understand and appreciate his role. So let's listen to Dr. Manu's talk on what he is acting as a quarterback of that MDT team. So what we can learn from his experiences. Thank you.
Thank you, and good morning. Thanks for having us. It's mind-boggling, or I'm getting palpitation following my mentor, and it looks like I'm following a giant, both in my day-to-day life and also being on this podium and being stuck between 2 of my big mentors, Prof. Edmonds and Dr. Petrova, who will come after me. So I feel a bit shaky now that having heard from Prof. Edmonds, and I'm sure Dr. Petrova will give you lots of research stuff, but I am just here as a mere diabetologist or endocrinologist and probably tell you just factual description in a simplistic term as what my contribution is or what I see as the principal role of a physician within an MDT. So I've got no disclosures, but my only disclosure is perhaps that this might be a rodeo to say, do you need me in your MDT? I felt as if giving this talk was like talking to my service manager to justify my existence within the MDT. But when I look at the task at hand, if this works, this picture depicts our typical diabetic foot patient. As you can see in the picture here, this patient has got, can get him out. Yeah, he's got a sign on his foot, just so that the surgeon remembers which foot the problem is on. And he's got a finger in his foot. Clearly, he needs to go for surgery. But what's he doing? He's sipping a cup of tea. He's completely detached from what is happening to his foot or what that danger is. And that is why we need to come together as an MDT to try and help this patient out, because he's got absolutely no acknowledgement of what is happening to his foot. No matter how much metal work you put in his foot, no matter how much you think you are worried about, you really need a big team around him, as Prof. Edmonds described. So why is that happening? And sometimes I try and simplify in a different way, as we talk about the fire triangle, that you need heat, oxygen, and fuel to cause a fire. But with the diabetic foot attack, 3 pathologies need to come together, i.e. the neuropathy, the immunopathy, and the vasculopathy. Those three aspects need to come together, and then that's when you have the diabetic foot attack. So you talk about the neuropathy part of it in terms of the Charcot foot or the deformity of the foot. We need to address that. You talk about the immunocompromised with the high blood sugars, the poor diabetes control, and the sort of multi-resistant organisms in the patient's foot on the immunopathy side. And also the vasculopathy side, not just the quantity, but the quality of the blood as well, also comes into play. So if we are going to arrest or firefight the foot attack, then we need to reverse all these three entities. And that's when the MDT concept comes in the role. So there's no way that Superman can address all these three aspects on his or her own. So we need an MDT to be able to replace those three facets that the patient has lost. And when I go through all those three aspects, maybe I may be biased or know better, because as a diabetologist, one of the things that follows the patient throughout this journey or all aspects is their diabetes or as an endocrinologist and their podiatry aspect. So if you look at the neuropathy side, you need a podiatrist to ask at the constant debridement of the hard tissue, or that you need a podiatrist, you need the orthotics to give them shoes. We need the orthopedic surgeons to reconstruct the foot when it is deformed. We need the nursing to help dress the foot. Again, we need the admin team. You talk about how the psychological aspect, these patients are detached from their foot. They need the admin team to remind them to come to the appointment. You need the physiotherapist, psychotherapist, as we are saying, that these patients do not feel they are unaware of their foot. You talk about the microbiology aspects. We need to improve their diabetes control. We need the complex regimes of antibiotics. And again, I usually say our podiatrists are the best antibiotics sometimes in terms of removing the biofilm from all these complex wounds. So you need their input on that side as well. You talk about the vascular aspect, plastic surgeons, and what do you call it? Intervention radiologists, cardiologists, the vascular surgeon, and sometimes even the angiologist to help us to improve the blood flow. And perhaps if I may sell myself, it's not just the quantity of the blood that goes there, but the quality of the blood. So again, I can probably say that as a diabetologist or endocrinologist, I may contribute there to make the lipids, the blood sugars, and so on, so the quality of the blood going to the foot or wherever you're operating on is better. So what is the role of the principal care physician in all of this? When I look at the journey that our patient has to follow through, it's a bit, I see it like a train journey, because you might have that aspect where you are implanting the metalwork or the section where the patient is ulcerated, that the patient comes to your attention. But as a lifetime, as we said, a high mortality rate that the patient will have an ulcer, the ulcer heals. It's like we're comparing to cancer. It is never cured. If they go into remission, they will re-ulcerate, they will break down, you put in the metalwork, even you try and resolve the Charcot will reactivate again, chronic phase, acute phase. So it's a constant journey. And who best to be in charge of the patient? As we normally say, the primary or the general physician may not be a specialist per se, but perhaps anyone with a diabetic foot complication needs to have a specialist that would take the patient almost like a train driver through all those expertise, because the specialist, the vascular surgeon, the orthopedic surgeon, the plastic surgeon, the renal physician will all dip in and dip out. Sorry. Will all be dipping in and dipping out. But who remains with the patient throughout their journey is perhaps where it comes to, as I said, I know no better, aspect from how I've been brought up. And Prof. Edmonds already described the system or the structure that we have got at King's, and it entails 4 diabetologists or endocrinologists who have got dedicated or dedicated interest in the diabetic foot. And that tend to be the principal physicians or the people who will be responsible clinically for the patients as they have their journey through the MDT. And with very close, so high patient quantities flow, but more draw attention to the need for the core part of the MDT. So we've got 4 orthopedic surgeons, we've got 2 dedicated vascular surgeons who are MDT, 3 plastic surgeons, and our microbiology consultants or infectious disease consultant. But the main backbone to the MDT is the podiatry. And here we've got Maureen Bates, our podiatry manager. And also one key aspect to make the MDT function and improve from research and innovation point of view will have to be through research, for which we are quite pleased to have Dr. Petrova, who you hear from later, to be the core, to be improving on everything that we do, and the aspiration to make every patient that we are seeing be almost on a research, rather on a control arm, or trying to improve what we do at every step. And then ultimately, limb salvage, preventing preventable amputation, ultradistal bypasses, as Prof. Edmonds had described, and the ability to conduct complex charcoal reconstruction can also happen. But if we look at, again, the patient's journey with the inpatient point of view, that again, perhaps it might be better placed if a diabetologist or a podiatrist leads that aspect of care. The system that we've got at King's is that the electronic referrals go to the podiatrist, who acts as the main gatekeeper, and the patient's aspect fall into about 4 main areas, whereby people with the foot complaints as their main concern stay in under the physician or under the diabetologist with dedicated beds for that. But also around the hospital, there will be patients who have got vascular as their main issue on their vascular beds, or on their orthopedic wards, or under the general medical wards. But the role of the main physician will be to ensure that there is a regular MDT ward round, like we do twice a weekly with the orthopedic, twice weekly with the vascular, and once weekly with the microbiologist, to try and make sure that we take this patient's trained journey, but someone needs to carry or lead or take ownership of that patient's journey through the MDT. Prof. Edmonds have already talked about the outpatient setup. In the UK, there's more emphasis to get patients out of hospital and try and avoid people being admitted to the hospital. And wherever healthcare system you're working in, maybe their priorities might be slightly different. So the model, again, that we have there is that someone has to have a principal responsibility for that patient in the outpatient setting. And again, bring in the expertise that the patient needs as and when needed, like Prof. Edmonds described the weekly pattern. So I find my role as perhaps the middleman, trying to bring in the various expertise that the patient needs at that point in time, working closely together with the podiatrist, of course, and then bringing the expertise. And Prof. Edmonds have already talked about the outpatient setup and the meetings that happens. But again, if I may sell myself a little bit, it's important for the peri and post-operative care of these patients. And for that matter, again, not to dwell on this, I'm sure you all know the possible impact of diabetes on your patients with higher mortality, ITU admissions, readmissions, in terms of people needing to be intravenous oxygen VRI, or the length of stay of patients with diabetes also gets longer, and the delay in surgery when people have got diabetes. So if I'm not stretching so much on the fact that you need a diabetologist, 5 main things that I want to go through. When we look at the UK, 1 in 6 hospital beds is occupied by someone with diabetes, and nearly 1 million of people are living with diabetes undiagnosed. In the US, it's even much higher. So the UK, about 6% of the population have got diabetes, which is nearly doubled in the US. And I'm sure you don't need me to tell you that perhaps 1 in 4 in people in hospital beds in the US have got diabetes. So, and again, Jan did explain that this is growing globally. It's a global issue. So understanding the diabetes is a key factor. When I used to have a full set of hair, diabetes was quite simple. You either had type 1 diabetes or type 2 diabetes. And it was very easy. You could say, okay, if you are young and lean, you've got type 1. if you are old and obese, you've got type 2. But that's not the case anymore. You've got people with young people with type 2 diabetes, and again, you've got people much older with type 1 diabetes. So that does not work anymore. Now, sometimes I need to look back to look at the different types of diabetes. So as a surgeon, I know there's a saying that the best surgeons think like a physician, but I struggle sometimes to get my head around the type of diabetes that our patients have got. So there are some types of diabetes that behave much more like a type 1 diabetes, i.e. insulin requirement. And with those, you need to have a better insight about how to manipulate their diabetes control around their surgery and their post-surgical recovery. And there are those types of diabetes that behave much more like a type 2 or insulin resistance. So again, the mindful of managing these patients metabolically is not as simple as grouping everyone together that they got a diabetic foot, because there are different types of diabetes. And do that different types of diabetic foot, do we put them all in the same pot? Or do we prep them for surgery and post-operative care in the same way? Of course, how they are treated is also getting more and more complex. So we used to have about maybe 2 or 3 types of diabetes tablets and maybe 1 or 2 or 3 types of insulin. But now there are numerous types of insulin. They used to have a short-acting and long-acting. Now you have a fast one, ultra-fast, and super-fast acting insulin. And you've got even much slower insulin, acting 12 hours, 24 hours. And now you can have a weekly dose of insulin. So managing these patients metabolically and perioperatively, again, as I repeat, can be much more complicated than we think it is. There are so many gadgets that these patients have, insulin pumps, insulin sensors, things that you take up when they're going for MRI, going for investigation. So I hope I'm selling myself or my services to you. But the bottom line, I think, is that we need to appreciate that the patient's journey is not just that surgery, 3-4 hours, beautiful operations that you do, but it's about the lifespan of the patients. And these patients will go into remission. They are never cured from their Charcot reconstruction. They will reactivate, and we need to appreciate that they need to be under the care of a specialist physician lifelong. Like I think like a colleague was asking, what do we do for prevention? These patients are forever, almost like having a cancer. They cannot be discharged to their primary physician and forgotten about, but they need to be lifelong under a specialist. And I may sum up what my role is in terms of having clinical ownership for the patients as you loan them up to their expertise, and being clinically responsible for what is running through the MDT and role in peri and post-operative coordinating the MDT. But like I said, most often I find myself as the middleman trying to sell off my patient to the vascular surgeons, the orthopedic surgeon, the plastic surgeon, the renal physician, the infectious disease consultant to try and get their input and bring in the MDT together. Occasionally, I need to stop them from fighting over each other. Sometimes the vascular surgeon say, no, the orthopedic surgeon should do it. The orthopedic surgeon say, no, the plastic surgeon should do it. But it is sometimes trying to bring the team together and being the peacemaker, and sometimes also pushing them to do much more. I think our surgeons can sometimes go over and beyond if they know that the patient will be well looked after from the physician point of view, that they can be in their OR or in theater knowing that the patient will be looked after post-operatively. And also, I think it's making sure to know which pieces of the puzzle to bring back to the table. Thank you.
We have time for a quick question with Dr. Manu, if anyone has one.
Hey, Dr. Manu. Should there be a captain of the ship? Establish yourself as a captain of the ship, or?
I usually call myself jack of all trade, but master of none.
Okay. All right. So the serious question is, how about the medical management of Charcot, and can we do anything to prevent or reverse a neuropathy from medical management? Do you know anything we can do to prevent? Because obviously the neuropathy is the source of all these issues we are dealing with and leading to amputation. So can we do anything at the front end to prevent or slow down neuropathy or reverse? Or even, and say, if the patient does get a Charcot, is there anything medically we can do
From the medical aspect of managing Charcot, I'm sure my colleague Dr. Petrova will talk about that aspect. What I'll concentrate on is perhaps the neuropathy side of it. And as a diabetologist, I think we understand that the neuropathy is caused by the glycemic injury. But what has made neuropathy very difficult to reverse or to come up with treatment for has still been the measurement of it. So, for example, with nephropathy, we have microalbuminuria that allows us to catch it early. And then we know that with good glycemic control, you can prevent the nephropathy from progressing. The difficulty with neuropathy is being able to identify it early enough. And then even when you try to reverse it, how are we measuring neuropathy? And again, perhaps that will be another 15 minutes talk. So is it the large fiber neuropathy, small fiber neuropathy? There are different types of neuropathy. But the bottom line, what we know is the glycemic control. That if we can keep glycemic control at a good level, then perhaps we can prevent neuropathy. But in terms of reversal, it's been very difficult to prove that or to demonstrate that. That's because once the nerves are damaged, they never re-innervate back to the same places. And with the Charcot side, I think the earlier we can pick it up, I think prevention at the moment is the key factor in just identifying it early and stopping it from progressing. Okay. All right. Thank you.
So I'm Dr. Nichols, by the way. We've been blessed to have the King's College team come out and really share their aggregated data with us and help us bring this concept to the South Dakota and Midwest region. To the end of aggregated data, we have Dr. Nina Petrova, who is a celebrated clinical researcher, 20 plus years experience. She's carrying on, she has a focus in Charcot foot and is carrying on Dr. Charcot's research well into the 3rd century following his birth. She's been supported by multiple grants, not only within her home country, the UK, but across Europe as well. I'm very excited to hear everything you have to say, and thank you again for coming.
Thank you. Good morning. Good morning, everyone. Well, I have a special, strange role. I'm a clinical researcher, and research nowadays, it's almost a passion. My name is Nina Petrova, and it's really nice to be here with all of you today. I'll mainly talk about the research on Charcot osteoarthropathy, and at King's we have a full cycle of projects that we have run through. We have worked on the pathogenesis and introduced novel in vitro methods to understand osteoclastic biology. We have carried out clinical studies with regards to bone mineral density, as well as thermal imaging and understanding of patterns of inflammation. We have looked into systemic markers, into the role of inflammation, bone turnover markers through advanced ELISA modalities. We are very interested into applications of advanced imaging modalities, magnetic resonance imaging, as well as SPECT-CTs. We undertook a phase 4 clinical trial using parathyroid hormone within a double-blind placebo-controlled trial. We have a great collaboration with our orthopedic colleagues, and King's is one of the established national centers for Charcot reconstructive surgery, and you will hear more about this tomorrow in the morning by Professor Venu Kavasapu. And in addition to this, in collaboration with Imperial, within my dual role within King's College London and King's College Hospital, I've been also looking into novel synthetic bioceramics and also application of novel advanced material science techniques into characterization of these properties. We have been fortunate to have had a few grants, support from Diabetes UK, Diabetes Research and Wellness Foundation, and also a Medical Research Council. And in addition to this, at present, we collaborate into a Horizon Europe program. This is led by University of Amsterdam. Professor Siko Bas, who will be a speaker this afternoon, is the project lead. And we are very proud that one of our podiatrists, Victoria Milburn, she's one of the 12 doctoral candidates, and her work is on biomechanical forces in Charcot osteoarthropathy, and she's undertaking these studies in University of Amsterdam. So what about the Charcot foot? I think we're all aware that this is a pathological response to injury, and it usually takes place in people with nerve damage, and it is most common now in people with diabetes. So we always think about neuropathy as the common denominator of all conditions which present with Charcot joints, but we would really like to make a point to a phenotype where perhaps neuropathy is less pronounced. And here is an example of a classical presentation, a warm, swollen left foot. You see the plantar bruising, indicative of Lisfranc injury, minor fracture, almost not invisible on the radiograph, but further imaging shows fractures in the metatarsals, in the metatarsal region. And this is happening on a background of normal bedside testing for neuropathy, normal monofilament studies, normal vibration perception threshold. Nevertheless, there is evidence of pseudomotor dysfunction, a sign for small fiber neuropathy, so preserved large nerve fiber, but abnormal small nerve fiber neuropathy. And this phenotype is quite commonly seen in people with type 1 diabetes, and it is usually unrecognized. And in addition to this, I will call it lack of clinical neuropathy at assessment. It's important to know that these patients present at a younger age. This is the bar charts show the peak presentation time for people with Charcot foot, and the white ones are in people with type 1 diabetes. And these are subjects in their 20s, 30s, and it is usually unrecognized. And it is really important to be aware about this early onset of type 1 diabetes. In addition to this, these people have more commonly osteopenia, which we noted during ultrasound measurements. And it is important to recognize these features: young age, small fiber neuropathy, and also peripheral osteopenia. So what about assessment? We have been quite interested to understand the initial bone lesion in patients presenting with a suspected Charcot foot. There is some swelling of the right. There is a suggestion of metatarsal-based fracture, but within a routine busy clinic, this can be missed if there is no high index of suspicion. And it is really important to be inquisitive, because you can see the extensive damage on MRI scan of the same patient involving both the metatarsal and tarsal region. And if recognized and offloaded at this stage, deformity can be prevented. And then the clinical outcome will be very good for the patient. We work very closely with our radiologists, and we have looked into ways to score a bone injury on X-rays and MRI scans, and we have looked into the agreement into findings from bone scans and X-rays, from MRI scans and X-rays in a cohort of 46 patients, and we looked into 961 bone pairs. And one really need to know that in only 20% there was agreement. And there was in 80%, almost 80% of the bone injuries, the X-ray findings were normal. However, there was either bone marrow edema alone or bone marrow edema with a fracture. And it is really important to be aware of this underperformance of X-rays, because on the X-ray that you see on the top, if you do not suspect a Charcot foot and if you don't treat this fracture, this will lead to collapse. In addition to early diagnosis, imaging is very important and actually can guide you to understand the pathogenesis of the condition. You see on your left a bone scan with a SPECT CT, and there is increased blood flow and increased bony uptake, a three-phase positive bone scan. And on the fused image, there is increased activity in the anterior part of the calcaneum, which on the MRI is also denoted as a fracture. So we have inflammation, and bone fracture is one of the initial lesions in the Charcot foot. But in addition to this, the CT component regularly shows subchondral cyst formation, which is a sign of increased bone lysis on the background of inflammation. So what is the link between inflammation and bone in people with diabetes and neuropathy? We have a discordance, we have a red hot swollen foot, we have local signs of inflammation, but that is not really associated with the rise in systemic markers, C-reactive protein, erythrocyte sedimentation rate, as well as white count. They're usually normal or mildly elevated in people with active Charcot foot. And at present, these are not recommended as diagnostic tests. However, they're useful in the differential diagnosis, in the assessment of the Charcot foot. And this is also has been noted in the international guidance on the Charcot foot. It's a bone injury. And we and many other colleagues have really looked into the importance of bone turnover markers. And all these studies collectively have shown that there is enhanced bone resorption, although bone formation is inadequate. And this really shows that the Charcot foot is associated with increased osteoclastic activity and impaired bone healing. And because there was a question earlier about medical therapies, as part of this knowledge, there has been some use of bisphosphonates as anti-resorptive agents, but these have really not been shown efficient in the management of the Charcot foot, and perhaps they may have been introduced quite early, quite late into the pathogenesis and presentation of the Charcot foot, because at the time when patients come to us, a lot of them have already developed some degree of bone and joint destruction. And in order to reverse this, we wanted to take a different approach. We wanted to enhance fracture healing. And for this, we carried out a double-blind, placebo-controlled trial in people with active Charcot foot, and we assessed the efficacy of parathyroid hormone as an agent, anabolic agents to enhance fracture healing. However, this study did not show any difference in time to resolution. It did not improve fracture scores, and therefore we concluded that it did not add any benefit in the management of the Charcot foot in addition to offloading. And perhaps one of the key areas of expertise and research that we have led on is studies associated with mechanisms of pathological osteolysis. Of the Charcot foot, you see this extensive resorption in Charcot bones in a patient, which indicates increased bone destruction, which is carried out by osteoclasts. And to study osteoclastic activity, we introduced for the first time in the field of Charcot osteoarthropathy an osteoclastic cultural assay. We took blood from patients and controls and isolated monocytes. These are precursors of osteoclastic cells, and we derived them into functional osteoclasts in the laboratory, and we studied osteoclast formation and osteoclast resorption when these were cultured on bovine bone discs. What we've shown that although there was no difference in the number of newly formed osteoclasts between Charcot, diabetes, and control subjects, when we looked into their resorptive properties, Charcot osteoclasts were overactive. So all these purple bits that you can see, so this is the osteoclastic resorption of the dentin discs. So there was increased area of resorption in Charcot cultures compared with diabetes and control. So they have this extensive potential to destroy bone. In the bone field, this is referred to as a bulldozer type of resorption, which is not physiological. And we extended these studies further using surface profilometry as a method used in material science to measure the profile of these erosions. And this is the graphical representation of one of the pits. And in addition to enlarged area of resorption, these pits in Charcot subjects were very deep and large, so a cell can destroy a significant amount of bone compared to a control cell from a non-Charcot patient. So these studies really show that in Charcot osteoarthropathy, there is abnormal response, enhanced response to RANKL, which is the driver, the cytokine that converts monocytes into osteoclasts. And there's been quite a lot of interest into the use of anabolic therapies, specifically a monoclonal antibody to RANKL in the active Charcot foot. And some early work from University of Amsterdam has shown an indication of enhanced fracture healing. And also there's been a study led by Schoeffler, which was an observational study, which also reported some benefit into the usefulness of this therapy. However, a more recent phase 2 study from Australia has indicated that there was no difference in time to disease inactivity, as well as time to as well as it did not reduce time to immobilization. And therefore, at present, the benefit of this therapy is unknown. I know that there are a few further studies which have not been reported, and it will be really interesting to see whether there will be a change in the scene with regards to medical therapy into the management of the Charcot foot. To conclude, I gave you a roadmap of a busy research work over the years into different aspects of the Charcot foot disease, and perhaps the best way to treat the Charcot foot is to diagnose it early, and a high index of suspicion is needed. Offloading is a key, and even if you're wrong, the actual benefit of preventing deformity outweighs the risk of giving a person a cast. Although there's been substantial effort in research in the Charcot field, I do really call upon further research and research funding. I think it's very rewarding to be a researcher and challenging at the same time, because I think for every grant which is funded, you need to write 15 in order to achieve the funding. So maybe we need to really change our understanding that the Charcot foot is a rare complication, because this is what I usually get into grant comments, and we really need to change our perception. And I'm so glad we have conferences raising awareness of this devastating complication of diabetes. Thank you for your attention.
Thank you very much, Dr. Petrova. Thanks for your elucidating some of the mechanisms that way. There was so much unknown that we in this field. I remember last year at King's College, that some audience asked a question: is there any medical treatment for Charcot? And I remember Dr. Edmonds answered simply, there's not. So it seems so many years we're dealing with diabetes. And then RANKL ligands has been, the theme of since our residency training is how osteoclast and osteoblast interaction. But in Charcot, is there any specific differences in Charcot patients? Is the belief that blood hemodynamics make any change for those RANKL ligands acting, or the inflammatory factor profile? Are there any differences from inflammatory arthropathy or trauma?
Thank you, Alan. I think I would really like to see further advances in the medical approach to Charcot foot, but I would agree that at the moment there are no recommended therapies. I think one of the issues perhaps with designing clinical trials in active Charcot foot is that the active Charcot foot is a broad spectrum of presentation, from minimal bone injury to advanced presentation with not only fractures but also dislocations. And I really think that instead of putting all patients into one trial, we really need to be thinking of a more of a tailored approach, rather than to be trying to find one therapy to treat all. And what's very interesting is that whatever you measure systemically does not really reflect what are the local processes. This relates to even like things like bone mineral density. One would assume that these patients have advanced osteoporosis, but they would usually have only peripheral osteopenia. Inflammatory markers are raised, but not specifically. We have done some work using measuring pro-inflammatory cytokines, TNF-alpha, interleukin-6. Yes, these are raised compared to those in diabetic patients, but these are expensive tests. I think we need to perhaps move from expensive tests in the lab and actually go and educate patients and healthcare professionals, exactly as Vinod mentioned in his earliest question, because the early presentation is the key to improve management.
We have one more question.
Good morning, Nina. Very nice presentation as always. Rodika Pobusui from University of Michigan for numbers of years now, Oregon Health and Science University. So I was actually wanting to ask you whether you can further elaborate a little bit. Can you hear me?
Yeah.
What Ellen has just asked, because definitely there is a lot of anecdotal information regarding how to treat Charcot, despite having actually the clinical evidence from randomized clinical trials. And looking at that phase 2 trial that obviously was not successful, could you elaborate perhaps how the trial should have been designed? Were the right patient population recruited into that trial? Was the outcome of interest correctly defined? And was the intervention actually being able to assess a change in some of these outcomes? Because as you said yourself, in order to make a dent, even if it is a very rare complication, it has devastated consequences on our patients. So how can we advise the design of clinical trials so that we can in fact learn some meaningful messages and not just treat patients empirically?
Thank you very much. I mean, that's a great question, because what is the best outcome? Is it time to immobilization? Is it time to reduction of skin foot temperature in the Charcot foot, which are usual time points in this group of patients? But whatever we measure at the end, we need to consider what goes initially in the trial. And even setting up criteria is, do we include patients with radiological diagnosis? Are they X-ray positive? Will they only have will they be patients who will have early presentation when X-ray show minimal or no damage, the so-called stage 0 Charcot foot? This is something which we really need to consider. And in addition to this, it's really important to know what are the outcomes that patients would prefer. Of course, for them, what matters is time to immobilization, deformity, and as well as quality of life. And I think it's really great that although the International Working Group has more than 20 years of experience, the actual first guideline on the Charcot foot was published in 2023, and there is a revision which is going to come next year in 2027. And it's really important that Charcot is now turning from a very rare complication into a complication which matters not only to patients but also to clinicians. So I think with this combined effort, we will be able to advance more the management and most of all the recognition, which is key. Thank you.
Thank you again very much for coming. Up next, we have Dr. John Steinberg. He's a professor of plastic and reconstruction, or within the plastic and reconstructive surgery department at the Georgetown University School of Medicine. He's here to share his expert opinion on functional diabetic limb salvage.
Greetings, everybody. John Steinberg in Washington, D.C. at Georgetown University Hospital with MedStar Health. Alan and Adam, thanks so much for the invitation to speak here. Sorry to not be in person, but happy to join here remotely and share some of our thoughts from Georgetown on diabetic limb salvage. So let me share my screen here and we'll get started. In our brief 20 minutes here that we have together, I want to really try to cover as much ground as I can. This is a discussion that Alan had challenged me with in regards to 30 years of experience in a multidisciplinary team in US-based tertiary hospital for complex limb salvage. And obviously our team was started here at Georgetown by Chris Attinger, plastic surgeon that many of you know and perhaps have worked with. Something that we all know and I learned extremely from my fellowship mentor, Larry Harkless, was that this phrase, coming events cast their shadow before, is so apropos for the diabetic limb. And this moment here in the operating room at Georgetown, where we're performing a drainage amputation, you can see we've got two patients unfortunately just lost their foot from diabetes. And this moment may be a life-saving and perhaps a function-saving procedure for that patient at that moment. But that means that a lot of things failed over the weeks, months, and years before that drainage amputation was performed that could have gone differently, that would have perhaps avoided that procedure for that individual. And that's what I would like to share with you, some thoughts on, of course, how we can perhaps avoid amputation for these patients altogether. This is a paper that we published in the PRS Journal in 2016. I love the concept here, and it really kind of speaks to the village. And it's a paper that really was designed to be read by hospital administrators. So if some of you are working in hospitals, HIS systems or practice groups that haven't really yet embraced the concept of functional diabetic limb salvage because they're worried about cost or worried about logistics or worried about patient volume in their hospital, this paper really speaks directly to that and talks about some of the finances even of this. And if you look at the authors here, Paul Kim, podiatrist, Chris Attinger, plastic surgeon, John Steinberg, myself, podiatrist, Karen Evans, plastic surgeon, Cam Akbari, vascular surgeon, Dee Benedict is rheumatology, Kelly Johnson Arbor, internal medicine, and hyperbaric oxygen, and then Brinder Singh is our hospital vice president. So the authors of this paper really embody the entire multidisciplinary team as a co-authored paper. So a great piece to share with your administrators or others who are thinking about starting a team if you need some literature to help back up your enthusiasm for doing this. One thing that I like to talk about is really becoming more than a wound care center. And while that may be the public marketing nomenclature that's best recognized by the layperson of, oh, I need to get to a wound care center because I have a diabetic foot ulcer, that's okay. But we hope that when they come to your wound care center, what they're getting is more of a surgical limb salvage based concept. And that is really marrying the inpatient and the outpatient teams together. And it's marrying the outpatient advanced wound care together with the inpatient advanced surgical options so that those are not separately existing entities. Those should be integrated as much as possible. And the same individual who's caring for that wound should ideally be the same individual who's also doing the surgical procedures for those patients when it becomes necessary. So we like that idea of the fully integrated team as I was charged to speak with here today. And we really try to make it an identifiable entity in the hospital. And every service at Georgetown University Hospital, especially the emergency room, knows that they should call the limb team. That's our name. We are the limb team or limb service. And we are the ones that they call when there is a diabetic foot infection. It takes that challenge away from the referring providers to wonder, well, do I call podiatry for this wound, or do I call vascular or plastics or ortho, or who do I call for this wound? They call the limb team, and we figured out from there because we are the multidisciplinary team, and they've engaged that with one single call to a single phone number. Vicky Driver and many, many others have published on this topic, but just a quick piece here from Diabetes Care 2005 to emphasize what we're talking about is that even in the face of a facility where Vicky was studying here, where diabetes was increasing rapidly in its presentation and the demographic of patient they were taking care of, the lower extremities, because of the implementation of a wound care team and a multidisciplinary team and a limb preservation service, lower extremity amputations decreased 82% in the face of increasing rates of diabetes, and the amputations were driven more distally to be at the foot and the midfoot and the toe rather than the below knee and above knee level amputations. Our Georgetown Limb Salvage team, as we mentioned earlier, a very expansive team. We know the data is hard and true that you can reduce amputation rates when you engage a limb salvage team. And your team doesn't have to have 47 specialties, but it does need to have some of the core principles of someone who can manage the foot problems and manage the foot surgery, someone who can manage the circulatory and vascular disorders, someone who can manage the infection. Those are all some key pillars that you need to find the right specialist to be your cell phone immediate access individual who you can engage when necessary for these patients. And this is a quick kind of schematic of how our team at Georgetown works. So starting at the base here we've got 3 operating rooms that run 5 days a week, 7 a.m. to 7 p.m. that are dedicated to our service. It's about 10% of the operating capacity of the hospital is fully for our limb salvage team, the integrated podiatric and plastic and vascular team. We have a large group of multi-specialty providers, including physicians, APPs, nurses, and techs that help design this and help this run. And we are obviously an academic team, so we've got 6 residents on our service at any given time, in addition to a fellow, in addition to medical students, in addition to podiatric medical students. But really big team. But if you're at a smaller institution, or even if you're in private practice and you're at this conference and passionate about limb salvage, you too can design a team that's right for your patient and right for your community and your geography. It just has to be the right group of folks that are available and accessible when you need them. The diabetic limb salvage really comes down to infection, ischemia, and biomechanics. And obviously, the reason that Chris brought me on in 2004 to be the first podiatrist as part of his team at Georgetown was that biomechanics was a big issue for his patients, and he could get most wounds closed, but they didn't stay closed. And those recurrent lesions from mechanical pressure and from abnormal gait patterns and from abnormal bony and tendinous issues were a major issue that needed to be addressed. And that's something that my specialty was able to help out quite a bit. But if you can go after infection, ischemia, and biomechanics, and you have a team that can address each of those, then you have the core principles of a limb salvage team. A lot of questions come up in regards to when should you decide on amputation versus salvage? And I'm not going to try to pretend to answer that here in this quick lecture because we've got so much else to cover. But this is a baloney amputation being performed actually by Chris Attinger in the operating room at Georgetown. And you could have predicted the direction that this was going when it was at the midfoot infection with necrotic tissue, or maybe you could even predicted it here when there was ischemic tissue and infection happening with a ray amputation, or maybe a little bit earlier when this was more of a plantar-based wound and more superficial. But if you try to rewind the time machine here and go back even further, maybe that wound started with this distal toe ulceration that was in your clinic that wasn't healing well from debridement and offloading, or maybe it was when it was this tiny small wound that the patient barely even knew they should come see a doctor for, or maybe it was before the ulcer was even a wound. Maybe it was just a callus with a little bit of dry heme in the area. So these are the lesions that we get excited about, is to try to intervene early now in these individuals and not just be reactionary medicine when things go really bad. So getting excited about addressing some of these mechanical deformities before they become a massively infected wound is one of the things that I spend a lot of time doing in clinic. However, we don't live in that perfect world of everyone comes in with their minor mechanical abnormality in their foot and lets us come and intervene and fix it surgically or through some orthotic or shoe device. Most of what we deal with in limb salvage is what you see pictured here, where we're trying to play catch up and try to save a limb for someone who's acutely threatened with tissue injury and has infection and ischemia in addition to bad biomechanics. So we fully embrace this concept that we've got to be ready at that moment the patient hits the emergency room. If you were to break this down into 3 questions of amputation versus salvage for a lot of these patients, I would say number 1, you've got to know, is the patient a candidate for limb salvage? That's a major undertaking, probably going to take many procedures, multiple trips to the operating room, a lot of anesthesia. Are they a candidate for it? Great, let's consider it. If they're not, then realize that amputation may be the more appropriate thing for them. Number 2, can you assemble the team? Do you have the specialists? Do the patients have access and a means to engage that team? And then finally, if you do all of this, will the patient really have a functional limb? Or are they perhaps better off having a primary amputation and drain that and get them back to walking in a few weeks with a prosthetic? So we're trying to get better about answering this proactively and not dealing with this reactionary situation of realizing 16 procedures later that maybe we should have just done a BK to start off with. So nobody's perfect at this question, but we're trying to get better at it and push that needle forward. We've got loads of data now. We're running a gait lab on a lot of our patients where we can do these small wearable sensors and get lots of data in a short amount of time without having to have $1 million gait lab separate area. They do this right in our clinic hallway when they come in for their post-op checks. So getting a lot of data, looking at cadence, looking at their stride length, looking at the actual comparisons between those that have neuropathy and don't have neuropathy, and much more to come in this, but really helpful to understand the mechanics of what happens when we do have a Ray versus a TMA versus a Liz Franks versus a Chopard's, and how does that affect their recurrence rates and their gait patterns. Tendon balancing is something I'd love to spend a few minutes on. Really, if we look at the reality of these individuals, a lot of their compensation, a lot of their soft tissue changes manifest in the tendinous structure of the low extremity. And these tendons are powerful mechanical influencers that can then influence the bone position, that influences secondary ulceration. So lots of small, ambulatory, simple, easy recovery procedures that are low risk can be done to address that, as you can see listed here, ranging from an Achilles tendon lengthening to a posterior tibial tenotomy. So we'll go through just a couple of those real quick and take a look. So I think probably the most underutilized procedure, and I know getting talked about a lot at this meeting, is the simple Hoke triple hemisection tendo Achilles lengthening. I really don't understand why this is not done more routinely for our patients that have equinus and diabetes. If you get into the habit of checking patients with a plantar foot ulcer that have diabetes and neuropathy, you're going to find that most of them have a degree of ankle equinus, and that can be quickly and easily addressed with a percutaneous TAL. Here you can see just quickly, we do this as part of usually our closure procedure if we're doing a toe or a ray or a mid-foot amputation before they get discharged from the hospital. Once that wound is clean, we'll do the closure, and then at final take back, we'll go ahead and do usually our quick triple hemisection. So 3 incisions, each cutting 50% of the tendon. You can see marking this out at 3, 6, and 9 centimeters from the Achilles insertion, using a 15 blade to cut half of that tendon width at 3 different locations. Very important that this is a lengthening and not a rupture, because if you rupture the tendon, those are the folks that go on to then have difficulty with calcaneal gaits and calcaneal ulcerations. So I like to put a simple suture in each of these and close each of these sites. You really could just put a steri strip on or not even close them at all. These are just percutaneous stab incisions here that you can see for these individuals. What happens after we've done a successful TAL? This is what happens after we've done a successful TAL. We can take a wound that's been there for months or years, and with that 27% reduction in forefoot pressure, we've got healing in just a few weeks. So that mechanical influence of that soft tissue balancing is huge and can be long lasting for these individuals. You can see here another individual ulcer that was present for years, debrided, grafted, but this time combined with a TAL, is healed up and stays healed in 4 weeks. A lot of questions about gastroc versus TAL versus doing a tenectomy or tenotomy. TAL is the workhorse for me in diabetic limb salvage. Occasional gastroc for folks, but I reserve that mostly for the athletic population, the reconstructing population, the non-diabetic population. It's just not powerful enough, in my opinion, to get enough pressure relief at the forefoot, if that's where your pressure is at. And then tenectomy or tenotomy, we reserve more for Chopard's amputation or for an aggressive Charcot reconstruction. So TAL really is the workhorse for me of posterior column lengthening. Mueller have studied this extensively and has published on this, that we get sustained plantar pressure reduction at 12 to 24 months, provides a therapeutic and preventive benefit for these patients. And really, the only thing you have to watch out for this is over lengthening, which if you do, I don't recommend rushing in and doing some emergent open repair. I just recommend keeping them immobilized in a cast for 6 to 8 weeks instead of a more ambulatory 3 to 4 week course. Shifting gears real quick to flexor digitorum longus tenotomy. When we do digit array amputations, we are going to get compensation in the rest of the forefoot. And if we want to fight and preserve the rest of those digits, we have to be ready for digital contraction. You can see on the right-hand side of the screen, commonly what happens is we wait so long to correct those hammer toes that by the time we finally do correct them, we're doing an amputation rather than a correction because they've got osteomyelitis. So what we're trying to do now is move that needle forward, move away from some of these more aggressive forefoot reconstruction procedures that need all kinds of vascular and medical clearances for anesthesia, and instead do what was published here by Mickey Stapp and Craig Kamast and others, where we just grab an 18-gauge needle and we do these in the office at the time they present. So here you can see exactly that happening in this individual who's had a prior hallux amputation. He's now got pressure at the distal aspect of his second toe. We're not going to wait 6 weeks to get him evaluated for medical clearance for anesthesia. We're going to take care of this right away. I do a quick little betadine prep of the toe, hold the toe in an extended position, have the patient contract against me, use the very tip of that 18-gauge needle. And in these neuropathic patients, of course, anesthesia is not even required. And then watch my left hand, and you'll see that flexor release give that immediate release to that distal toe. And this is with him actively trying to plantar flex or curl his toe down. We're able to release that tendon, put a quick little bacitracin and gauze bandage on this, and these wounds go on to usually very uneventful healing. So here you can see 2 weeks post flexor digitorum longus release that was done in the office with complete healing and rapid turnaround for these digits. So a very, very safe and, in my opinion, a very underutilized procedure that is slowly getting more popularity. Great data was published on this in 2022 in Diabetes Care. They looked at 95 randomized patients with ulcer versus impending ulcers. They found that the healing rates favored tenotomy significantly, with 100% versus 37.5%, lower incidence of progression onto ulceration in those who were at risk, and really had no serious adverse events. So very little reason to not do a flexor tenotomy when those patients present with a distal toe ulceration. Do all amputations need tendon balancing? Yeah, most of them. Maybe not all, but most. If you can really go after this with appropriate minimal reconstructive techniques of doing some of these tendon balancing procedures that I've mentioned and others, you can address some of their limited joint mobility, you can address some of their foot deformity, and you can address some of the abnormal foot pressures. These are 3 of the most common reasons that someone forms a diabetic foot ulcer, and you can take that off the table by doing something as simple as a toe tenotomy in your clinic. Great case to kind of summarize and close and wrap this up for us here. 67-year-old male presented to Georgetown, really well-controlled diabetes, but also has a history of HIV, and transmetatarsal amputation was performed, and he was scheduled for a more proximal amputation, and he transferred to us for limb salvage. And you can see we had to keep debriding, and now we've got him to a very proximal TMA, but there is no dorsal flap, there's no plantar flap, and we've lost a significant portion of his plantar soft tissues as well. So complicated medical patient. Now he's a complicated surgical patient because, of course, the easy answer here is to just go take this back to a show parts or a Symes or a BK amputation and make that his terminal procedure. But he was motivated, and we were motivated to not accept that answer. So instead, we rallied our team, and between revascularization and a free tissue transfer performed, and then combined with tendon balancing, where we did a posterior tibial tendon release and a tendon Achilles lengthening release, this patient got a free flap. He got salvage at his TMA level and is fully functional, fully ambulatory, and also has a decreased risk for repeat ulceration because we've also addressed the biomechanics that caused him to get that midfoot amputation in the first place with his tendon balancing as part of his free flap and his closure. So this is how we tie all this together. And these are the persons that we tie it together for. These are our patients who look to us and depend on us at some of their most vulnerable moments in life and some of their most scary visits to the hospital or your clinic, where they're wondering whether they're going to be told that they need to have an amputation. And it's your skill set and your passion that can turn that conversation in a very positive manner, in a very great direction, to hopefully offer the appropriate patient an appropriate limb salvage procedure. There's so much that we can do now compared to 10 years ago, especially compared to 20 or 30 years ago. And when we can rally these multidisciplinary teams, it is these patients and your patients who need it, who depend on it, and who benefit from this type of passionate, high-level care. So with that, I'll share my email here. If you have any questions or have any clinical discussions you'd like to send my way, please shoot it to john.steinberg@medstar.net. And again, Alan and Adam, thank you so much for the invite to speak. Hope to see all of you soon. Enjoy the rest of the meeting. Thanks so much.
All right, moving right along, we have Dr. Larry Lavery, professor and clinical researcher within the UT San Antonio system now. Plethora of research that he's put out. He's a very, very big name in the podiatry world. He was also my fellowship director. He had less gray hair until he met me. But we're here to listen to his risk stratification and other insights as regarding getting these folks taken care of.
Yeah, I don't think I had any gray hair until you were a fellow. Yeah. Anyway, so thank you very much for the opportunity to come and speak at this meeting. So I'll tell you a little bit about some of the data I'm going to share in my pathway here. 25 years ago now, the university was going to partner with a private group to do a amputation prevention disease management program. Really similar to the thought processes that people talked about. The thought process isn't rocket science. And so we partnered with Humana, we partnered with a disease management group in New York City. We had so we did projects in San Antonio, and we did projects in Corpus Christi, which has the same amputation incidence as an Indian tribe in the United States. It was like 400 per 10,000. Really not very good care, not organized well. And so that company was eventually sold for $800 million to, to United, which promptly disassembled all the pieces that worked and wanted to do disease management light. I don't think this is a process that you can do in an expedited way. Okay, so that being said, at a meeting not dissimilar to this, probably 15 years ago, Peter Cavanaugh sent a bunch of people an email and said, tell me what is the most important innovation for the diabetic foot. So if y'all don't know Peter, he's an engineer, really one of the leaders in the diabetic foot. And so, people responded. So this is Nicholas Schopper. He's an endocrinologist. He's now retired in the Netherlands, and he was one of the founders of the International Working Group on the diabetic foot. And so I cannot advance my own slides. No. There you go. So what Nicholas said was, we need to do what we say we're already doing. It's like, we don't need innovation until we're doing the foundational pieces that we know work, that we get together 5 times a year and say, we know all this stuff works, but we don't do it. We don't put it in place. And I think that there are, like the program that the people from King's talked about today, I mean, that's not done well or done often. And especially in environments like Sanford or Baylor Scott & White is a big health insurance plan in Central Texas. And it used to be a physician group that then was bought by it used to be Scott & White, which was started by Dr. Scott and Dr. White, and then Baylor bought it. And it's an insurance company, not a medical group. And places like Kaiser in the United States or the Veterans Administration are ideal places to do disease management because they're more worried about good clinical outcomes than how you make your money. Many of the physicians are salaried, so you can do things that I must have got this. Do things that people in private practice don't have the team to do. A lot of what I'm going to talk about today is you can find this work in the International Working Group on the Diabetic Foot's prevention guidelines. There's a number of guidelines. So some of this, like these 5 key elements of prevention, I just took from their guidelines. So I've been a part of the guidelines, probably for I was part of the prevention guidelines probably for 4 or 5 sessions, and I've been on the infection guidelines. So this last year I kind of stepped away from prevention because it was a lot of work. Today I'm going to talk about identifying high-risk people, a little bit about inspecting the foot because it follows the classification system. And then I'm going to talk about the benefits of education, footwear, and a little bit about some innovation things. There's a growing body of evidence that not everyone knows about or really embraces. And so, part of the question is, is it the high-risk patient or is it the high-risk physician? I mean, are we just not doing our job? And we could be much, much more effective, especially in environments like Sanford, where you can organize and, it's good for the organization, it's good for the patients. So what's the opportunity? I think the lower extremity opportunity is great for a disease management focus because it's common, it costs a lot of money, it's easy to identify the highest risk people that are going to benefit from care immediately. Recidivism is high, prevention works, and if you're doing a disease management program, you'll find people with disease early, pretty much what some of the things that John Steinberg talked about. So your treatment is easier. You're doing elective cases. The vascular surgeon is doing elective revascularization, not emergent revascularization in an infected limb that you're trying to salvage. But on the other hand, this is Tantalus, and Tantalus never gets a sip of water and he never gets the fruit from the tree. But I think it's important that we, continue to reach. So if you're interested in the guidelines, they're well documented, they're evidence-based. It's not necessarily an easy read. I mean, they're really done well, but you won't have to go and dig up the most important literature. They're going to provide it for you. And the new guidelines should be coming out in a year. So these are from 2023, or I believe. Okay, so this is just a little bit about the guidelines. So it's written by clinicians, researchers, and experts in the area. And, it's, so let me just go back. So these are the areas that they focus on now. They added Charcot arthropathy. Finally, this last session, Dane Lukic was the chair of that session. So it's a dynamic document. It changes with the literature. It helps identify areas that need research. And I can tell you things in the infection group that were consensus that, basically it means at midnight when everyone has had 2 scotches, it's like, yeah, agreement gets a lot better after the second scotch. But there were things that we didn't have evidence for. Now for many of those things, we're replacing evidence with our opinion. And a lot of time your opinion misses, your feelings about how the disease process works or the mythology that you were taught isn't right once you look at the evidence. And it's one of the reasons why I have been interested in research as part of my clinical career, because I wanted to know the best pathway for my patients. So yeah, okay, this was probably a slide that I thought that. So, part of the problem with this disease process is everyone thinks the diabetic foot is one thing, although we discussed today that it is not. There's a whole bunch of different parts of this. There's not a single answer. There requires some tailoring for our, high-risk patients, and especially when a team is used to addressing all the parts and have, a group of consultants or people that are part of the team that can, as everyone else has said today, revascularize your foot, take care of the infection, address the biomechanics, et cetera, et cetera. So it's not necessarily as straightforward or black and white as a lot of people would agree. And there's been a couple slides like the blind man and the elephant. So there's an ID person that I've worked with for 10 years. And God bless her, she still is like the real problem with the diabetic foot is infection. Everything is infection. It's like, I love you, but we're going to call the vascular surgeon. So, I think we have a growing body of evidence, but we're not using it. I mean, the last guidelines or the, some of the recommendations for the American Diabetes Association, there's better evidence to prompt our decision-making. And I'll share some of that with you. So I'm really going to start by talking about the risk stratification. This was really a system that was stolen, borrowed, adapted from what Carville had. So a lot of people, their journey started with Paul Brand, and just like Mike Edmonds said. So I went to the Carville Hansen Disease Center when I was a first-year resident. and really changed my perspective and what have you. So the big difference in the Carville system was they didn't have vascular disease. So this is the current system that's adopted by the International Working Group on the diabetic foot. So LOPS is loss of protective sensation. So sensory neuropathy and no PAD is risk group 0. Risk group 1 are people that have neuropathy or PAD. Usually the people in this group, when they have PAD, they have neuropathy as well. Risk group 2 is people that have neuropathy and structural deformity or neuropathy and PAD together. And risk group 3 are people that have a history of a previous ulcer or amputation, or in the last guidelines, or maybe 2 guidelines ago, we added dialysis or end-stage renal disease as an additional risk factor. So the guidelines give some recommendations on how frequently you should see people for follow-up. And really, this is one of those things that is really based on opinion. So this is from a disease management program that I was involved in. This is the first 1,666 people that were screened. And this is a disease management program that excluded people on dialysis, right? It didn't belong to, I think this was a Humana-based study. So about 60% of people had low risk. 6% had loss of protective sensation or PAD. Almost all of them was just loss of protective sensation. Risk group 2 was 20% and risk group 3 was 16%. So this is what the yearly incidence of ulceration, amputation, and hospitalization was in this group. So we followed these people for 2.5 years. And if you look at the original paper, we have first ulcer, multiple ulcers, first amputation, multiple amputations, first infection, multiple infections, et cetera, et cetera. So there's more granular detail in that, but I think this will help with the point. So it's like, okay, if you are Baylor, Scott and White, or Sanford, or the VA, probably not the VA because they don't care about where their money is spent. If you're going to target your money, it's probably going to be the people that have most of the disease. And so the first 3 groups, they have a really low incidence of ulceration. So if you were going to power a study to improve a 3% ulcer rate, you're going to enroll thousands of people to show that you can get from 3% to 2% or 1%. So there aren't any studies that are powered to do this, although there are some studies, or actually quite a few studies, that have mixed risk groups. The next group is people that have PAD. So it's about 14% of the people that have PAD ulcerate every year. So this is the big significant jump, right? When you add PAD, and usually this is PAD plus neuropathy, almost 100% of the time, I think it's PAD plus neuropathy. 4% have amputations a year, 16% are hospitalized. So this was part of a disease management program. So our shift after the first year was people were identified, they had non-healing wounds, and they were revascularized before it was an emergent event. So our hospitalization changed. There weren't outpatient vascular surgery procedures. There wasn't a lot of endovascular stenting when this program was done. So most of these people were hospitalized or revascularized. That's the increase in hospitalizations. The big jump is if you have a previous event. So even though people got education, there was an orthotist on site that provided shoes and insoles. They were replaced frequently. We walked them on a forced plate. After they had their shoes, we had an in-shoe pressure measurement thing. We, changed we gave them new insoles if it didn't look like their treatment was better. And still, a third of those people re-ulcerated. And those are the people that had more hospitalizations, more amputations, more repeat events. So it's real. So Pareto was, I think, an Italian economist. But there's a lot of things that kind of approve the Pareto principle or event, where 20% of the population accounts for 70% of in this group, 70% of the ulcerations and 90% of the hospitalizations. So if you were the health plan manager here, you would just do a search from your CPT codes and identify people that had an ulcer or an amputation in the last year, and that's where you would do your prevention program. And those are the people who are going to gobble up most of your resources and where you're going to be most cost effective. Damn it. Well, I know I'm not finishing, am I? Okay, so I think this is a simple risk stratification tool. You get the biggest bang for your buck looking at events you can identify easily. No one is going to have a good PAD diagnosis for the general group in your community. You're going to have to do that manually. That's the next highest level of time they're going to spend. So people with a history of disease, man, that's where the money is. How expensive is it to prevent the first ulcer? I'll share some. I don't know if I broke it down, but there's not a ton of data about this, but it's a lot more expensive because the events are relatively rare. Next, I'm going to talk about educating the patient or their family. So it ends up, when you look at the literature, we do a horrible job of sending people in the United States that are at high risk for having a foot problem for a formal education program. Also, I looked at data at Scott and White, and they had a 45-minute education system. Guess which system had diabetic foot education? Right, number 4. So that being said, a whopping 8% of patients were sent for foot education out of a high-risk group. We looked at 150 people that had ulcers and 150 people that were dialysis patients. We just didn't send people for education, and when they went, they didn't go because no one attends their last session. So this is the meta-analysis, and this forest plot is about randomized clinical studies that look at diabetic foot ulcer events as a clinical outcome. There's 9 studies that are RTCs. One of them doesn't look at ulcers, it looks at amputations, but it's not a significant improvement. So the relative risk was 0.8, the p-value was 13%. There was no difference in ulcer incidence in people that had education and people that didn't get education. There's a couple problems with this. What you got for education varied so tremendously from a single 45-minute education session to programs that had 9 sessions. There were programs that had personal coaching and group discussions and hands-on application. So really different level of engagement. Most of the studies didn't provide regular foot care or therapeutic shoes and insoles as part of the prevention program. And so in clinical practice, I think education is underutilized. I think it's essential, but it has to be part of all the other things that you do. I think by itself, it falls apart, which I think is what the literature supports. I also think we tell people to do things in education that they can't do. So I've had a couple Dutch fellows, and usually before they leave the airport, they're like taking pictures because Americans are so obese. And but we tell people, hey, you should look at your foot every day. And they either have limited mobility, their hip and knee, or they're too obese or they have visual impairment. So they can't position their body to see their foot. And if they do, their vision is so poor that they can't identify a problem. So, so this is just a little data. Some of this data is from UT San Antonio, where we looked at, I think we looked at 230 people. But these were my patients. Like 15% of the patients were legally blind in one eye, at least one eye, and I didn't know it. Now, when people are like looking at you trying to find their visual field that works, that's a hint. But 48% of people had visual impairment, 41% couldn't position their foot to see the bottom of it. So 54% of our patients overall were telling them to do things that they could never do. And then similar results in a dialysis cohort. So what about shoes and insoles? Well, we don't do this very well either. This is an old paper from Gail Reiber's group at the University of Washington that showed less than 3% of Medicare beneficiaries that are eligible to get therapeutic shoes and insoles. There's a bunch of bureaucratic reasons in the United States why that isn't done. But I looked at that data in Scott and White, and 7% of high-risk people were sent for shoes and insoles. I mean, in a clinic setting where the ped orthos was literally on our hallway. So it's like you have to go down out the door and go left, walk 10 meters and go right, and the ped orthos is right there. So the first thing, I think the most valuable initial step is removing the shoe as a source of pathology. That's part of the education process. There are 10 RTCs that look at diabetic foot, shoes and insoles, and ulcer as an outcome. There are 9 cohort studies. 2 2 are prospective, the 7 are retrospective. Some of the early work was done by Mike Edmonds. So this is the data when people have bespoke shoes and insoles and is compared to their self-selected shoes. 4 randomized clinical studies that look at that. There's a 48% or 46% risk reduction. It's significant. If you look at, there's 6 studies that have an enhanced bespoke shoe and insole, a new way of, a CAD/CAM generated insole or something else. Yeah. And in those groups, it was a 41% risk reduction, but it's not significant. The p-value is exactly 5%. So, if you want to be a statistics, hardliner, it's not significant. But both of these, look to be effective interventions. All of the cohort studies were positive because there may be some publication bias because people probably wouldn't publish a cohort that's negative. This is just a simple example of what we did. We would make people insoles, walk them in the F-scan InShoe system and look to see if we can reduce the pressure at their highest pressure point. So the number needed to treat is small. If you compared people with bespoke shoes versus self-selected shoes, the number needed to treat was 14. Also, the time for people to have an intervention. So this is a survival analysis from a study that was done in Rome. I mean, at 3 months, there's a significant, change in the survival analysis. Early improvement for a relatively low cost. So what about other innovative treatments? So there's a whole bunch of things that people have talked about a little bit today. I'm going to talk about temperature monitoring. There's really a growing body of nice work about surgery, showing it's safe, and probably best of all, you heal wounds and recurrence rate is really low. There's some great stuff, interesting stuff with activity monitors and new ways to make shoes and insoles and fat pad augmentation with silicone and other fillers. The rationale for using temperature monitoring is so people can identify an area that's injured they wouldn't normally be able to see and have objective data to do it. So it's this guy. The person on the far left has a hot spot on the ball of his foot, and the idea is to identify it. You can identify it really 30 days before you see a change, and it's places that are exposed to regular injury. You cannot feel with the back of your hand. You could probably feel 8 degrees Fahrenheit with the back of your hand, probably if you're 25. The idea is people aren't going to recognize a mechanical injury because they have neuropathy, and you're not going to be able to see the difference. So there's a whole bunch of different tools that are commercially available. There's a lot of literature using thermography when people are just doing the measurements themselves because, people aren't going to pay $150 for a thermography camera. But there are new instruments that are inexpensive. And the one in the middle is a prototype of a couple studies that we did. So usually you're comparing sites to see if there's a 4-degree Fahrenheit difference, 2.2 degrees Celsius difference. And then the treatment was decrease your activity by 50%. So now everyone has an activity monitor on their phone. There are 9 RTCs in this space. And if you look at this, the risk reduction is 50%. For most of these studies, they include other treatments. So the 50% reduction is in addition to what you would get with seeing a podiatrist on a regular basis and having therapeutic shoes and insoles. So it's an incremental improvement. The number needed to treat is small, and the time to see a benefit is also really short. Again, it's probably about 3 months before there's a separation in their survival analysis. Of course, people that don't use the technology, they don't have any benefit. Now with remote temperature monitoring that you can Bluetooth and someone else can analyze it and send you a warning, you can identify the people that fail. Yeah. There are codes in the United States for remote temperature monitoring. So now you can get paid to do it. So in summary, if you have diabetes and a history of ulcer, 50 to 80% of people re-ulcerate in a year. If you do standard prevention, that's cut to 30%. If you use temperature monitoring in addition to shoes and insoles and regular follow-up, that is less than 10%. So thank you for your attention. And I think we just need to go back to what Nicholas has said. We need to do the things that we know work. They're inexpensive. They're easy for us to incorporate. It's having the administration to organize and maybe a proper quarterback. So thank you all. Appreciate your attention.
Thanks a lot, Eric. All right. This is time for stretching your legs, and please visit our vendors. Without our vendors' support, this meeting is not going to come. And also, let me remind all surgeons, trainees, please sign up the labs for tomorrow afternoon. DPM, our podiatry surgeon, MDs, and residents. Please do that. And also, if you can sign up for the social event, so we know the number. Okay, thank you very much. And also, this is cowbell from Midwest. So once you hear it, we're going to coming back. All right, thank you. Okay, so following our now. Is it working? Oh, now it's working. I'm sorry. So following our general session, and now we still the multidisciplinary model, and we moving on to the vascular and the plastic portion. And we have like a very important key figures, leaders in this topic. And Dr. Joseph Mills, and he is the first author of Wi-Fi system. It was widely used internationally for diabetic foot reconstruction. And he is one of the influential leader in this field. And we started with his talk, and followed we will have Dr. Attinger, who is the father of the blood flow of the diabetic foot reconstruction. And we leave our question after those two important talks, and then we start our lunch session. Okay, and now we start with Dr. Mills' talk.
Good afternoon. This is Joe Mills, Professor of Surgery at Baylor College of Medicine in Houston. It's a pleasure to be with you virtually. I wish it could be in person. Today we plan to talk about Wi-Fi and how it's useful in daily clinical practice. I have no conflicts of interest to report. And all the consulting I do, the fees go to the Baylor College of Medicine and not me directly. So I get asked this a lot. Why do we even want to classify things? And I think the answer is pretty simple. You want to establish the diagnosis, define the disease extent. You want to be able to risk stratify the patient and predict the natural history of a given stage. And then you'd like to be able to assess response to therapy and compare different modes of therapy. So we published Wi-Fi in 2014 as part of the Lower Extremity Guidelines Committee for Society for Vascular Surgery. And it increasingly has become popular. It's been endorsed and recommended by, among others, the Society for Vascular Surgery, European Society for Vascular Surgery, the World Federation of Vascular Societies, the American Heart Association, and the International Working Group on the Diabetic Foot. And it's been cited over 2,000 times now, which is rewarding. So why did we need Wi-Fi? Well, the previous systems were outdated, and the concept of critical limb ischemia was never intended to be applied to patients with diabetes. And if you look back at the Rutherford and Fontan models, they were pure ischemia models with a cutoff for a circulatory abnormality that would be severe without considering infection, which is a profound problem with patients with diabetes. So if you look at this study from Eurodial, and they just defined PAD as having an ankle brachial index less than 0.8. If you added PAD plus infection, it tripled the risk of amputation in patients with diabetes, and yet infection wasn't even mentioned in Rutherford or Fontan. So we decided to put things together. So what do we know about perfusion? We know that in most patients, there's an S-shaped or sigmoid curve, and the classic patient with a pure neuropathic ulcer from motor and sensory neuropathy with palpable pulses of warm foot and normal perfusion, no matter how you measure it, they end up on the top part of that curve. But patients on the extreme low end of the curve have really poor perfusion. Unless they have a trivia wound, they're not going to heal at all. And then what do you do with all the patients in between? So all these patients here I've taken care of over the last 30 to 40 years, all had saved limbs except the patient on the lower right for complex reasons, which I won't go into. So I thought, how could we put all this together into a classification system that was meaningful? So if you remember one thing from this talk, remember that what Wi-Fi is meant to be for chronic limb-threatening ischemia in the diabetic foot is just like TNM for cancer. So we stage every cancer and we assess treatment response by stage. And we do the same thing and can do the same thing with CLTI and diabetic foot ulcers. So instead of tumor, we have wound. Instead of lymph nodes, we have ischemia. Instead of metastases, we have foot infection. And each of those can be graded from 0 to 3. And the combination of those grades gives you a clinical stage, which corresponds to the patient's risk of amputation at 1 year. That was the original intent of Wi-Fi. So you grade the wound, grade the ischemia, grade the degree of infection if present. And then I'm not going to go through this in detail, but basically each of the stages corresponds to progressively increasing severity. So the wound, why you say, why is a patient with a grade 0 wound in the study? Well, they could have ischemic rest pain and a toe pressure of 15 and an ankle brachial index of 0.3. With severe rest pain, they're at risk for amputation even without a wound. And as the wounds become more complex and as ischemia becomes worse, and as we adopted the Infectious Disease Society of America classification for infection, if you put all these together, what we did was we had a Delphi consensus of all 16 members of the committee and said, okay, if you see a patient with the following grades of ischemia, infection, and wound, where would you put them on a risk of amputation? So you can see here, patients with ischemia grade in 1 and 2 don't meet the old definition of critical limb ischemia, but it was felt by the committee that if patients had a significant wound or certainly any infection, they would be at high risk for amputation. So basically, we came up with 4 clinical stages based on estimated very low risk, moderate risk, or high risk of amputation. So this is supposed to predict the limb outcome based on limb disease severity, much like TNM is cancer severity. So the good thing about this is there's an app now that you can use, which you can put on your phone. I do this in clinic and calculate Wi-Fi on all my patients. And this was estimated amputation risk that we proposed when this was first published, that stage 1 and 2 would be fairly low, stage 3 would be intermediate, and stage 4 would be really high. So in the first few years after Wi-Fi was published, you can see here, these series were published and it panned out pretty well. So stage 1 patients had a 3.2% risk of amputation at 1 year, stage 2 almost 7%, stage 3 between 8 and 9%, and stage 4 was 24% even with revascularization. So clearly how aggressively you treat a patient and how you counsel them should depend on their stage of disease, just like we do with cancer patients. This was a meta-analysis done by a group in Europe that looked at almost 2,700 patients in 12 studies and looked at the 1-year amputation rates for Wi-Fi stages, and they were 0% for clinical stage 1, 8% stage 2, 11% for stage 3, and 38% for stage 4. Now, again, most of these were retrospective. So what else could you do with Wi-Fi? Well, you can audit and compare outcomes in your facility stratified by limb risk. Again, if you don't have the limb risk, how can you classify your outcomes? It'd be much like not knowing the breast cancer stage and trying to compare breast cancer treatment outcomes between different centers. Also, it may allow you to restage the patient and see if they're responding to therapy and might help in improving selection of procedures. So a little bit about that. On the left here is a study from Japan, and these patients got endovascular therapy only. In blue is wound healing rate, in green is limb salvage rate, and in red is requirement for repeat endovascular therapy. And you can see it, for example, in the stage 1 patients, they all healed and no limbs were lost. In stage 4, they only lost 20% of the limbs at 1 year, so limb salvage was 80%. But almost half the patients had a non-healed wound, and the patients had undergone a mean of 2 to 3 operations to try to endovascular procedures to try to salvage the limb. This study on the right is not randomized, but it was from Conti's group, and they took these same patients, Wi-Fi stage 4, and the patients that had bypass had much improved outcomes as far as limb salvage compared to those patients with endovascular therapy only. Now, this is another interesting study. It shows as you progress from left to right from Wi-Fi clinical stage, blue is debridement in the operating room. Maroon is minor amputations. green is any revascularization, sky blue is endovascular revascularization, and plastics reconstruction is there in brown. And as you progress from Wi-Fi stage 1 to 4, you can see that the need for all these things, so the care becomes more complicated as you progress. This is a very interesting study, and one of the few I know of that's been done, that looked at Wi-Fi clinical stages by grades of wound, ischemia, and foot infection at 1 month, and showed the 1 month grade of each of those correlated with outcome better than the baseline grade, which is analogous to TNM for cancer. So if you gave a patient a certain course of therapy for their cancer, and at a certain interval of time afterwards they hadn't improved, you would alter their therapy. This suggests we should do the same thing. If there's still ischemia, it should be corrected if possible. If there's still infection or it's worse, it needs to be drained. And the wound obviously needs to be addressed if the other two have. So it could be useful in periodic assessment. And several centers, including ours, do this at every visit. Now, finally, I'm going to conclude. This was a really interesting recent study from Best CLI, which I'm sure you've seen. But if you look at patients with diabetes, even with grade 3 and 4 wounds down here, so they're the worst of the worst. This line here, anything to the left of it favors surgery. So those patients did better if they had surgical bypass than if they had endovascular therapy. Now, what was interesting is this was just published, and you may not have seen it, but this was the first time, to my knowledge, there's been multi-center prospective validation of Wi-Fi, and they had data on over 1,500 patients. And when they compared Wi-Fi stage 4 and stage 3 with stages 1 and 2, which overlapped, the major amputation rate in Wi-Fi stage 4 was double. The death rate was 1.3 times higher, as was male-in death, as was requirement for intervention. So it shows that advanced clinical stages, particularly 3 and 4, correlate with worse clinical outcomes. So in conclusion, I think that if you use Wi-Fi, it broadens the potential risk group of patients who might benefit from revascularization, and recognizes that CLTI is a disease spectrum. It's not a yes or no, it's a disease spectrum with stages, just like cancer. And multiple studies now have shown that Wi-Fi correlates with 1-year amputation risk, amputation-free survival, wound healing time, and wound healing rate. So if you look at the 4 grades of wounds and the 4 stages of Wi-Fi, there's some overlap with amputation risk, but the wound healing time and wound healing rate separate out really well for the 4 stages. It also correlates with major adverse limb events, or MALE, after revascularization, and hospital length of stay. All are important things when you're analyzing your own outcomes. So in conclusion, data support the predictive ability of SBS Wi-Fi lower extremity threatened limb classification system, because limb disease burden when you first see the patient has a significant impact on outcomes. Larger wounds and those with infection mandate expedited care and early revascularization once infection is controlled. And there is emerging evidence, especially for advanced clinical stages, that if the patient has a vein conduit and will tolerate it, a vein bypass first may be better in the long run. Again, the Global Guidelines Committee, some of you in the audience may be participating this year. These are being redone. This was published in 2019. A new version will be coming out in 2017. I think we're all in this together. I took this picture in Lyon, France, after we first presented the last global guidelines, and it takes a whole team of patients, of providers and physicians and nurses working together to save feet. And I wouldn't be able to do this work without our own team at Baylor, which consists now of 5 vascular surgeons and 4 podiatrists who give meticulous care to our patients. And with that, I will thank you for the privilege of talking to you and your attention during this talk. Thank you.
Okay. All right. Those are the real concepts. And we move along with the Dr. Chris Attinger. So this is the critical theory about reconstruction. It started from plastic surgeon Ian Taylor in 1987. And then, so the angiosome concept, that is some concept that I never learned during my residency. Now I got into the problem when I get into a subspecialty in foot and ankle. This is not hip, this is not knee. So you got a lot of wound issues I do not know why they come up with. And later on, I learned from Dr. Chris Attinger that angiosome is probably the problem and we do not understand it fully. So let's listen to the insights and the father of the foot and ankle angiosome, Dr. Attinger's talk. Thank you.
I'm delighted to be here to talk to you about the key angiosome concepts in foot and ankle limb salvage reconstructive surgery. I have no disclosures. This is a worried patient coming into your office with blue, cold feet. This is a pleased patient with well-vascularized feet pruning himself. I'm going to talk to you about angiosomes, the concept, the angiosome territories, the collateral flow, regional areas of ischemia, and how to apply the angiosome concept for better outcomes. This is a patient who has a booming posterior tibial pulse and yet has this ulcer that is not healing. Angiogram reveals that there's no dorsalis pedis or perineal artery, explaining why this wound is not healing. The angiosome concept was invented by Ian Taylor, where he split the body into blocks of tissue fed by named arteries. And that three-dimensional piece of tissue is known as a angiosome. Here you see the medial plantar artery angiosome, which is three-dimensional, feeding the instep, and in this case, the hallux, as well as the underlying tissue and bone. We're going to go over quickly the anatomy of the arteries here. The two common iliacs that split into the superficial and deep iliac that then become the common femoral. The femoral artery then splits into the profunda, which feeds the thigh, and the SFA, which feeds the lower leg. The popliteal artery then splits into both the anterior tibial artery, which is the first takeoff, and then the tibio-perineal trunk, which is medial to that, and the posterior tib and perineal then split off the tibio-perineal trunk. And then once you get down to the leg, you see that the posterior tib feeds the plantar foot with two branches plantarly. The anterior tibial artery feeds the dorsal foot, and the perineal artery feeds the lateral ankle. All three arteries are also linked should one of the arteries stop functioning. And this is what we'll talk about at the end, which is all valuable, especially in our population with so much peripheral vascular disease. When you listen to an artery with a Doppler, you're looking to identify triphasic flow, which would signify normal blood flow, biphasic, which is abnormal, and monophasic, which is even more abnormal. You can only trust a triphasic signal. Otherwise, if you have suspicions, you need to get a duplex or an angiogram to document the patency of that vessel. The perineal artery feeds the lateral aspect of the posterior leg, the lateral ankle, and the lateral heel. It goes deep and also feeds the muscles underneath and along the lateral aspect of the leg. The perineal artery then splits into a delta, where it sends the anterior perforating branch to the anterior lateral ankle, and the posterior calcaneal branch, which feeds the lateral heel. To find the anterior perforating branch of the perineal artery, one has to feel for the soft spot just anterior to the distal fibula, and that will enable you to find the signal there. The perineal calcaneal branch is about 2 centimeters distal from the lateral malleolus, and that should make it easy to find as well. The perineal artery and the anterior tibial artery are linked by the lateral malleolar artery. We'll talk about that later, but that shows you that these two arteries are connected. If you want to check for antegrade flow of the anterior perforating branch, you first find the perineal artery, and then you would occlude the dorsalis pedis to make sure that you're not getting contributions from the anterior tib for the signal. Here you see a patient who has an ulcer over his lateral malleolus that's not healing, And despite a posterior tib, you can see that there's no anterior tib or peroneal artery, and hence this has little chance of healing. Here you see another patient who has a lateral lower leg ulcer. And when you look at the angiogram, you see that the perineal just dies out in the mid-calf. And as a result, this wound will not heal based on the lack of blood flow. The territory of the lateral calcaneal artery and of the posterior tibial lateral plantar artery is the glabrous junction. It's very important when you decide to make an incision to make it between both angiosomes, otherwise you'll end up with non-revascularized tissue. Here you see the posterior tibial artery, which is similar coverage of the lower leg as a perineal laterally. It covers the medial aspect of the leg and then goes and feeds the medial ankle and plantar foot. And this is three-dimensional as well. Here you see a patient who has a large ulcer medially, and when you look at the angiogram, there's no posterior tibial artery. The posterior tibial artery has three smaller angiosomes: the medial plantar artery, the calcaneal branch, and the lateral plantar artery. Each have their own territories. You hear the blood flow before the split of the three arteries, and if you want to make sure it's antegrade, you can occlude distally. The first branch that comes off is a calcaneal branch, which feeds the entire heel. And here you see the Doppler. You can Doppler that artery out easily. Here you see a patient who has a non-healing wound. And when you get the angiogram, you note that the posterior tibial artery is occluded and there's no calcaneal branch. The medial and lateral plantar arteries serve the plantar foot. The medial does the instep area and the lateral does the rest of the work. And here the medial plantar artery has a superficial branch and a deep branch. And you can make sure, if you're using a flap from the instep, you can make sure that there's antegrade flow by occluding possible retrograde flow. And here we're using the superficial medial plantar artery to fix an ankle defect. And here we are listening to the deep branch, which you can also use to harvest the same flap. And here's a patient who has a heel ulcer secondary to squamous cell carcinoma. And we then created a flap based on the deep branch of the medial plantar artery, and we rotated it in position. And here he is with a healed wound. The lateral plantar artery you can Doppler after the medial branch branches off, and you can check for antegrade flow by occluding it distally. And you can check for retrograde flow by occluding it proximally. The anterior tibial artery feeds the anterior compartment and dorsal foot. The anterior tibial muscles are fed by the anterior tibial artery. There's no other arteries feeding it, period. That's not true for the lateral compartment and superficial and deep compartment, where there's multiple arteries feeding the muscles. This is why this muscle, the anterior tibial muscles, suffer the most in a compartment syndrome. Here you're listening to the anterior tibial artery, and then you can occlude both the lateral malleolar artery and the proximal dorsalis pedis to make sure you have antegrade flow. Here's a patient with a non-healing ulcer. And despite having a booming posterior tib, you can see there's absolutely no flow in that area, and that will not heal. The dorsalis pedis is a continuation of the anterior tibial artery and feeds the dorsum of the foot. And you can see the arteries that come off it to feed the extensor digitorum brevis muscle, as well as the dorsal metatarsals. The next very important topic is to consider the direct vascular connections that allow these arteries to keep having blood flow because there are connections between each of them. For example, the anterior tib and peroneal artery are joined by the lateral malleolar artery. The dorsalis pedis is linked to the lateral plantar artery, and underneath the Achilles tendon, the peroneal and posterior tibial arteries are linked by arterial connections. And these are all important, and so you can actually predict what kind of what the angiogram looks at by occluding or not occluding and seeing what the direction of flow is. Here's the connection between the anterior tibial artery and the peroneal artery via the lateral malleolar artery. And here is the dorsalis pedis linked to the posterior tibial artery via the arch. And this is all important. You can see that on the left you have a normal angiogram, on the right you have no posterior tibial artery, but because the arch is intact, the plantar foot is getting blood flow in a retrograde fashion. In order to determine whether the flow of the dorsalis pedis is antegrade or retrograde, you would occlude the posterior tibial artery and see if you still get a signal. And vice versa, if you want to see if your arch is open, you can occlude the anterior tibial artery at the area where the lateral malleolar artery is and see if you get retrograde flow from the posterior tib. You can also occlude the dorsalis pedis and check whether the flow from the posterior tib is antegrade or retrograde. And here you're doing more refined examination of the lateral plantar artery. Here's a real dilemma is when you do a TMA, you may have good flow dorsally, or you may have good flow plantarly, or you may have both. Don't assume that you have the same blood flow in both. In this instance, the posterior tibial artery was feeding the dorsal portion of the foot, and the minute they cut that connection between the two, i.e. the arch, the dorsal foot went on to die. And in this instance, there was a connection between the dorsal and plantar connection, and when you cut the dorsalis pedis, which was feeding the plantar foot, the posterior flap went on to die. Here again, you see the anterior tibial and peroneal, anterior perforating branch of the peroneal connection via the lateral malleolar artery. And here you know where you would pick up that signal from the anterior perforating artery. And if you occlude the dorsalis pedis, then you can tell whether that flow to the peroneal artery is antegrade or retrograde. And obviously in this instance, you see the peroneal artery is feeding the dorsalis pedis via that connection of the lateral malleolar artery. The other connection that's important is between the posterior tibial artery and the peroneal artery underneath the Achilles tendon. And here you can see that the peroneal artery is feeding the posterior tib and providing blood flow to the plantar foot. And here you see where there's no plantar artery, but you can see that the peroneal artery provides blood flow to the plantar heel. Now, this is a film showing you what we talked about, how to use a Doppler, and enabled you to have a much more sophisticated evaluation of the vascular system.
Okay, that concludes our morning session. We now have 20 minutes to visit the vendors and pick up lunch and then head into the Coyote Room, which is the room kind of at the opposite end of the hallway here. We'll have a lunchtime presentation about Matroderm. So feel free to get up, move around, grab the lunch and head that way.
Yeah, again, I will have ring my cowbell when the time is up for the afternoon session. Okay, enjoy lunch and our lunch session in the different rooms. We have lunch session talks there and visiting our vendors as you can. Don't forget to sign up the labs for tomorrow. All surgeons, medical students, residents, and the non-surgical staff for the total contact cast, hands-on lab, therapist, orthotist. There is something for everybody tomorrow afternoon. Great session. Don't miss out. Just sign up for us. Thank you.
Okay, perfect. All right. All right. Now I'm good. All right, let's get started. My name is Dr. Peter Bellezza. I'm a podiatrist with Avera Orthopedics, Avera McKinnon Hospital here in Sioux Falls, South Dakota. We're a level 1 trauma center, and I do a lot of diabetic limb salvage and wound care, and I've been in practice for almost 10 years. And so over the course of my career, I've used a lot of different products for complicated wounds, and I've come across Matroderm, which is got a unique structure, and it's been really, really helpful in some of my most complicated wounds that I've been dealing with at the level 1 trauma center. So we'll kind of talk about some of the advanced applications of this product in soft tissue trauma and limb salvage reconstruction. These are my disclosures. So what is Matroderm? Matroderm is a single-use acellular dermal matrix. It's got a 3-dimensional porous scaffold that consists of 3 different collagen, type 1, type 3, and type 5. It's got the deliberate addition of elastin, which comes from bovine ligament. There's definitely some other dermal matrices out in the market that have elastin in it, but it's more naturally occurring and it's variable. This has 3%, which has some significant advantages that we'll kind of discuss a little bit later. It's manufactured by an advanced cryosafe method. Another unique feature of this is that it has no chemical cross-linking, so the body can grow into it very, very quickly, and it helps build back tissue extremely fast, as we'll demonstrate with some of the cases that we show later. It's been very popular in Europe for over 30 years, 200 publications, 128 human clinical use studies, 13 randomized controls trials, data that adds up to be 12 years of follow-up. This is not a new product. It's just new to the United States, but it's been around for a long, long time, and there's a lot of strong evidence supporting its benefit. So what are the benefits of bovine collagen 1, 3, and 5? Well, these are natural binding sites that help with complete cellular infiltration in about 3 to 4 days. It allows the tissue to vascularize in 3 to 7 days, and it can fully remodel into host collagen in 4 to 6 weeks. The human and bovine dermal collagen is about 97% identical compared to fish matrix and pig matrix. So what are the benefits of elastin? Well, it's got superior functional aesthetic outcomes, which increases collagen dwell time, which allows for optimal tissue regeneration. It enhances angiogenesis, which is actually really helpful in some of the wounds that we deal with, just because these patients have peripheral vascular disease and diabetes, which affect perfusion to the wound base. It helps with minimize scar severity and increases skin pliability and decreases skin contracture, which is really, really helpful in burn wounds. When looking at some of the head-to-head studies of just comparing split thickness skin grafting alone compared to Matroderm and split thickness skin grafting, there's statistically significant extension elasticity and less retraction when we use Matroderm for skin grafting compared to skin grafting alone. And there's no chemical cross-linking, which means very, very fast healing. The body recognizes this tissue, it grows into it very fast, and we can have significant deficits that we can fill in about 3 to 5 days. It's really advantageous to do one-step split thickness skin grafting with this product. This was a patient of mine that had a lateral ankle abscess. We did an IND, did a wound back. The wound bed was fully granular. There was a little bit of deficit at the anterior aspect of the wound. We put some Matroderm in there, which is about 1 millimeter thick in this case, and then we did a split thickness skin graft, and this allows us to get rapid closure. This was another patient of mine, 40-year-old African-American male, not healthy. He's got end-stage renal disease on hemodialysis. He's a smoker. He's morbidly obese. He had a chronic dorsal foot wound that was being managed by another podiatrist in Nebraska. They did some type of skin substitute. They had uncontrolled bleeding afterwards due to just calcification of the vessels. So some of these smaller hospitals just transfer these patients to us, and we have to manage them. So I just debrided the wound with a Versajet and put a wound vac on it. About 7 days later, the wound bed was pretty good. This patient had significant lymphedema, so he had a little bit of a crater there. But for me, this wound bed is optimal for a skin graft. And so I'm going to use the Matroderm 1 millimeter to kind of build back some of that tissue and get some skin directly over it.
So this is us cleaning the wound. This is the matroderm, which we hydrate with saline, which kind of forms like a very thick adherent paste to the wound. It's not really going to move. You don't need to fix it with suture or staples. It's just going to stay in the wound. And I personally took a thicker skin graft here and placed it and secured it with staples. And for me, my protocol is I put a wound vac over this for 1 week and we don't touch it. Then I mobilized the patient in a splint. This is about 7 days later. We had definitely some revascularization of the skin graft. It's definitely alive. It's remodeling. We looked at it 9 days later because he was still in house. We see some epidermal lysis, but underneath there's healed skin, and we were able to get this guy closed who was dealing with this wound for quite some time. Due to the lack of chemical cross-linking, again, we can get fast closure. This was another patient that was transferred to our facility that had a non-healing partial calcanectomy wound. For me, he's already lost the attachment of the Achilles. My objective is to try and get the wound closed as quickly as possible. He just wasn't healing, so we went ahead and removed some of the bone, and we debrided the wound, and we packed it with the matroderm, which will kind of form a new neodermis right over that bone and help vascularize that skin. And so we were able to close almost all of the wound, except for the central aspect. And for me, any type of posterior heel wound, I'm going to protect this in a butt frame. No questions asked. You know, a root boot doesn't cut it. A waffle boot doesn't cut it, especially in some of these patients who are very large. And so I put them in a butt frame to create a no tension environment here. That's not going to cause any disruption to the skin healing. And I did an incisional wound vac. This was about 7 days later. As we can see, the skin is healing quite well at the proximal distal aspects. In the central area, with a little bit of wound care and collagen, ended up healing. We got the frame off and we put the patient, he's getting fitted for an AFO. So is matroderm the best dermal matrix? I would say so. I mean, it's got a unique design that gives it a lot of added features that's supported by preclinical, animal, and clinical studies. The unique addition of elastin enhances angiogenesis to the tissues, which again is advantageous for some of these wounds that we're dealing with that have peripheral vascular disease and comorbidities that kind of delay healing. Its non-cross-linked native structure, again, allows the tissues to recognize it, grow into it very fast, revascularize very fast, unlike some of the other dermal matrices that will take about 2 to 3 weeks to fully heal. We can make up a lot of time using this product. We can do early skin grafting with this product. And again, the rapid vascularization lowers the infection risks. You know, when you compare it to some of the other products that take about 2 to 3 weeks to heal, that have a silicone layer on it, that silicone layer is a nidus for bacteria. I can't tell you how many times that I've used similar products that look good for the first week and then they get contaminated, and then we're only get 25, 50% in growth. And then we're going back and having to use the same product again. We're losing time. The patients can have complications from infections, and then we're just going backwards instead of moving forwards. So we're going to go straight to some pretty exciting cases here. So it's case number one. This is a necrotic heel. 66-year-old patient with a history of smoking. He had a gangrenous heel from frostbite. He was homeless, never sought care, was brought to our ED. Really, really terrible wound, obvious calcaneal osteomyelitis. We did get vascular studies on him, which returned normal. He just got a frostbite that never got treated. Complete disintegration of the posterior heel, fracturing of the heel due to the infection. And so in these cases, you know, the patient did not want a baloney amputation. So we're going to utilize all our resources to try and get this patient healed. So the first step was an aggressive partial calcanectomy by removing all the non-viable bone. For me, in these cases where there's contaminated bone, I'm going to use a product that's got calcium sulfate, hydroxyapatite, and gentamicin in it. I drill holes into the infected bone. I inject this material in there. It's got a high concentration of gentamicin that's going to kill bacteria and create an ideal wound environment for wound healing. And then I put that dermal matrix right across over it, and I stacked it about 4 to 6 millimeters thickness and did a wound vac. So again, this is that product that we inject into the heel after we've drilled it several times, and I kind of just plaster it right over the bone. This is what the wound looked like after we did our aggressive debridement and we did our matroderm. We did some partial closure there, and we just threw a wound vac on this patient. I did not put this person in an external fixator because I just wasn't sure whether or not this was going to look good or not in 5 days. but we came back in 5 days and the wound looks significantly improved. We are seeing some of that dermal matrix already incorporating into the tissues and building back. That other product that we injected into the bone is killing bacteria simultaneously, creating a very clean wound environment. And so this is definitely salvageable in my book. And so we're going to go back again. We're going to re-debride the wound. We're going to put some more dermal matrix on there, and I'm going to stage this for a reverse sural flap. Patient had really good blood flow, no peripheral vascular disease. All we really need is an open perineal artery, and this is what we're going to do. So we did a stage 1 procedure where we re-debrided it. We put some more matroderm on it. I put the patient in a butt frame, and I staged the reverse sural flap, which is a muscle fasciocutaneous flap from the proximal leg. We detached the superficial artery, providing blood flow to that area, and now it's going to get retrograde flow from the perforators from the perineal artery. And so that's what we did. We came back and this is just a picture on the floor. As you can see, the wound continues to improve with more wound vac therapy. And our flap that we created is alive. I kind of spread stage 1 and stage 2 about 10 days or so, just to ensure the flap is going to survive. And then since it did, we went back and we did our stage 2 procedure. And again, as you can see, the heel wound continues to make significant progress because of that matroderm product kind of filling it in. And so this is our reverse sural flap. We open up, we create our pedicle. Within that pedicle has the blood flow from the perforators from the perineal artery, which is near the lateral malleolus. And then this is our rotation of the flap, getting complete coverage of that heel wound, great perfusion, no tension. So we're able to get complete coverage and recreate that heel pad that is missing. Prior to closure, I do put some more matroderm underneath the skin because, again, I feel like it does develop a new neodermis that vascularizes the skin and helps with wound healing. And so that's what it looks like when it's all closed. Initially, I used to skin graft any open areas, but now I kind of leave them open and I do wound vac therapy for that just to fill it in to get it to the level of the skin. And then I'll go back and skin graft. And so this is about 9 days later. We're seeing great remodeling in the flap. The flap is alive. We've recreated that heel pad. So we're going to come back and skin graft now that that donor site is at the level of the skin. As we can see, everything is surviving. Even that open filleted part of the posterior leg is looking good. We're not seeing any skin edge necrosis. And that looks beautiful. So I harvested skin from the contralateral leg. And again, same thing I always do. I wound back it for about 7 days. And so we're moving so fast here that I figured this guy's going to have calcaneal gait because he's lost his attachment to the of the Achilles. I'm going to go ahead and fuse this guy because I want him to walk. I don't want him to rely on any prosthesis or device for the rest of his life. So we're going to go ahead and fuse the ankle. Now, for me, I'm a little bit aggressive when it comes to this stuff. Yes, he's being treated for a bone infection in his heel. But in my opinion, we injected some of that material into the bone that's providing local antibiotic therapy to the bone. He's getting IV antibiotics. We're going to be fusing bones that are not infected. I'm pretty nifty with an MIS burr, so I didn't even an openness. I just did an MIS debridement of the ankle joint. I inject more of that calcium sulfate, hydroxyapatite, and gentamicin in there since this is a high-risk fusion. And as you can see, the day of the surgery, everything is remodeled, everything is healed, and we proceeded with our ankle fusion. And in 4.5 weeks, we did a debridement. We did a stage 1 reverse sural flap, a stage 2, a split into skin graft, and an ankle fusion all in 4.5 weeks. Got this guy closed in less than 5 months, fixed his mechanics, going to save his leg. And it's the only reason we can move so fast is because of this dermal matrix. Any other product, we still be waiting 2 to 3 weeks just to see if the wound is even filling in. So this is a dynamic product. It's really changed my limb salvage practice, and we're going to continue to show you some cases here. So we get a lot of farm injuries here in South Dakota. This was an auger injury, 56-year-old male, type 2 diabetic. He smokes 2 packs of cigarettes a day. Got his jeans caught in an auger, got sucked in, pretty much lost the entire posterior ankle, his Achilles, his FHL, the FDL. He lost his posterior tibial artery, the vein, the tibial nerve, the sural nerve, the saphenous nerve. Miraculously, he still had good perfusion coming from the anterior tibial and the peroneal artery. For these traumatic wounds, orthopedic trauma usually is the first call. Not that they want to do it, but they usually are. So they went ahead and they tried to clean up the wound. I thought they did a serviceable job, but with these farm injuries that are polymicrobial and have a lot of contaminants in it, there's high risk for tissue death. And so they repaired the skin as best they could. They threw a wound vac on it. I wouldn't have done anything different. Unfortunately, there was significant tissue death. They consulted plastics, who in my institution is not excited about lower extremity wounds, especially in diabetics and especially people that have neuropathy. They just say, cut it off, and then they sign off. So every institution is a little bit different, but in my institution, they're just not very excited about this stuff. So the patient does not want their leg off. So the only other person left is podiatry. And so they're like, hey, podiatry, can you save this leg? I'm like, all right, we'll see what we can do. So I had, great plans to kind of repair the wound more. And we get in there and the wound is now twice the size. Tissue, more muscle death, more skin death. And we're kind of working up our way up the leg. And I'm like, what am I doing here? But we kept on debriding until we got the healthy tissue. I did not take any intraoperative photos after this case because I just wasn't optimistic that this was going to heal. And I kind of regret that now. But for me, we have to give this patient the best chance of healing. So that, again, that's a butt frame to get the posterior leg off the bed. It cannot be on the bed. You have to get it off the bed so that the tissues can heal. You have to immobilize the foot so that the tissues can heal. If you're not doing that, you're not doing the right thing. And so patient was doing hyperbarics inpatient, then we transitioned to hyperbarics outpatient. We did a couple more debridements in the outpatient clinic to try and optimize the wound. We have some bone exposed. We have some peroneal tendon exposed. I took him back for another operative debridement in October, did some more wound vac therapy, then used the Matroderm product in December. And as we're starting to see, again, this is just 5 weeks later from his original injury, we're starting to see some granulation tissue forming and filling in. This is me using the Matroderm, hydrating with saline. Again, it forms this thick gel over the wound. You don't need to secure it with suture or staples or anything like that. It just stays there. The wound is now looking phenomenal after a couple of applications of Matroderm. So again, this is 8 weeks from his original date of injury that we're at this point. So this is, again, working very, very fast. And so we're going to do a split thickness skin graft for this guy. And so I harvested skin from both his legs. We did 1 millimeter Matroderm over the wound, harvested skin from both legs, piecemealed it together, keep them in the frame always until it's completely healed. Again, I do a wound vac for about 1 week undisturbed. And as we can see, that skin is growing in. That neodermis that's hypervascularized is vascularizing the skin very, very well. We're not seeing any necrosis. It looks great. It continued to remodel about a month later. For me, this is clinically healed. Again, this patient had calcaneal gait because he lost his Achilles and all his posterior compartment musculature. I don't want him to be in a crow boot forever. He wants to be a farmer. Even if he wasn't a crow boot forever, he still is pretty high risk for heel ulcers due to the lack of muscle that he has in the posterior leg. So for me, I'm going to fuse him with a retrograde nail. Again, I'm pretty nifty with an MIS burr, so I don't have to open this. He already had a massive wound that he just recovered from, so I'm just going to make small stab incisions and get this guy healed. So I take down the ankle joint, I take down the subtalar joint, we do our nail. Patient's healing very well in February. By May, he's got a healed fusion. He's walking in a shoe. He's back to farming. His skin is completely remodeled. It looks fantastic. We are going to see the elastin in display here, where he actually has some good pliability of the tissue. It's moving. It's not the original skin, but it's better than just scarred down tissue. But it looks more like normal tissue, and he had a massive gap, soft tissue deficit there. So soft tissue recon in 13 weeks, bone recon in 16 weeks, got this guy healed up in about 7 months, and he returned to farming, and he's doing really, really well. So this is one of my cases. I did a total ankle replacement on somebody. Incision was looking great. 3 weeks later, we took the sutures out, it dehisced. We're looking at the anterior tibial tendon. The ankle capsule was not violated. There was not really an acute infection, but for me, I'm going to act very, very fast for this because this can go south very, very quickly. So we took him to the OR. I wrapped the tendon with Matroderm. I packed it underneath the skin. I tried to close the wound as much as I could. And then we wound vacked it. In this case, I did not put him in a frame, but honestly, I probably wish I did because it would have healed up probably faster than it did. This is what it looked like about 10 days later. It's starting to look very, very good. We're starting to see it fill in from underneath. About a month later of just keeping him off his foot, the skin continued to remodel. We didn't have to do a skin graft. The collagen matrix kind of reepithelialized and formed new skin. And then this is him healed without having to do a free flap, without having to do any type of muscle flap. And you can see that anterior tibial tendon is in its normal place. It's not subluxing, and he's got good range of motion, and we can finally get him up walking and rehab him from his total ankle replacement. This is a heel degloving injury in a pedestrian versus motor vehicle accident. Patient had numerous orthopedic injuries, so orthopedic trauma was initially consulted on this patient. They basically did a debridement, they fixed his bone, did all the bone work, and then basically handed off the heel to me. We did lots of wound care to try and get this wound base ready for a skin graft. Because he didn't want me to harvest skin from his legs, he wanted it from his thigh, so I referred him to plastic surgery. They did the skin graft, but they didn't do any type of offloading or immobilization for this guy. So he's a big guy, as you can see. So he got a pressure injury through the skin graft, and it died, got infected. So I took him back to the OR. I said, I'm just going to take over your care. This is what it looked like. We did Versajet, removed all that non-viable skin, put him in a butt frame because we got to get protection off that posterior heel envelope. Did a wound vac, did Matroderm, came back in 5 days. Wound bed is pristine. So this guy's ready for a skin graft. All right, so just in less than a week, we're ready to get this guy skin grafted and do this again. So we harvested skin from his leg. We did Matroderm, put the skin graft right over the Matroderm, got complete coverage. Skin graft is healing. Some of it definitely uptook, definitely made the wound smaller. We did not get complete healing from the skin graft. I attribute that just to his severe swelling, which is really hard to manage when the patient's in a frame. We had some epidermal lysis. There is some reepithelialization occurring here. So we did some more outpatient wound care with some placental products to kind of close down the wound. It's looking better. He does not want another skin graft. So I said, okay, we can use a product that is skin allograft donor, and we'll still, clean up the wound and use Matroderm. So Matroderm is a versatile product. It works for all different types of products. It doesn't matter that it's bovine. It works just fine with human tissue. So we threw this product over it. We injected some PRP into the wound bed. We did another wound vac. This is what we look like now. Wound is a lot smaller. It's still pretty healthy, but it's still a work in progress. We're still working on them. But slowly but surely, we're going to get this guy healed up, and we're going to continue and then eventually get him out of the frame and finally get him started with rehab. This was another calcaneal osteomyelitis that just came off the street. I admitted him right away. He had significant peripheral vascular disease. We got vascular surgery involved. They did a revascularization. He only had perineal artery runoff. That was it. But because he has the perineal artery, we can still do a reverse sural flap on this guy. So again, we did an aggressive debridement of the wound, inject calcium sulfate, hydroxyapatite, and gentamicin to provide local antibiotic therapy to the bone. We did Matroderm, wound vac, butt frame, hyperbarics, IV antibiotics. Wound's still not looking that great, but we have to be patient. So we took him back and redebrided it, did more Matroderm. Wound is starting to turn the corner here. 4 days later, still looking better. About less than 2 weeks later, the wound is fully granular, but again, it's pretty much neodermis and bone. This is not going to last. We have to recruit some soft tissue to recreate this heel pad. And so we staged this. We did our fasciocutaneous flap, detaching superficial sural artery proximally, relying on the retrograde flow from the perforators from the perineal artery. Come back in 10 days, the flap is alive, so we're ready to move forward with stage 2. And so we're going to unzip the leg, develop that nice pedicle. We're going to put some matroderm underneath the fasciocutaneous flap because, again, I feel like it helps with the flap healing. If for some reason the fasciocutaneous flap was to break down, we still have that matroderm underneath it. So we really didn't lose any soft tissue ingrowth, and we can do some spot treatment for that. So again, this is the rotation, complete coverage. And this is when I used to skin graft immediately. Doesn't work. Just give it time. Just let it fill in with the wound vac and then go back and do it. So we did have some breakdown of the skin graft in the middle incision. He did only have one vessel runoff, so I attribute a lot to that. But again, this is just some collateral damage that just needs some wound care. But the flap itself survived. It looks fantastic. So we tuned it up in outpatient wound care. He was ready for a split thickness skin graft. We took him back, did some more matroderm, did some spot touching up with his own skin, wound back it again, and he got completely healed out. This patient did not want his ankle fused, so we have him in a crow boot, and his heel is holding holding strong very well. It's not breaking down. This is my last case. So this was an infected total ankle from an outside surgeon. So 60-year-old type 2 diabetic, had a total ankle done. Patient was controlled with her diabetes, done by an outside surgeon. Pretty much non-compliant from right after surgery, started walking on it two weeks after. Developed an anterior ankle wound dehiscence, did not follow up with the surgeon. So this dehiscence completely broke down and developed an anterior ankle abscess. She ends up showing up to my ER. I'm on call. And I called the surgeon. I'm like, want to manage this or do you want me to manage this? And he's like, you can manage it. I'm like, thanks. So I went ahead and did what we needed to do. We cleaned up the wound. We explanted the total ankle. Again, I used this product that has calcium sulfate, hydroxyapatite, and serum and gentamicin in it. And I use that as my antibiotic spacer. It really conforms to the deficit very well. It gets very hard. And it's providing significant local antibiotic therapy to the bone. We went ahead and debrided the anterior ankle wound with the first jet, and I just packed that wound with as much matroderm as I could. And if a lot of it doesn't fill in, so be it. We can always go back and put more in. Then we went back and we debrided it again a couple times. We put the patient in a frame, and then eventually we did our bone reconstruction with a PEC 3D implant. So I'll kind of walk you through this. So that's kind of what we were dealing with. Gross dehiscence, gross infection, malodorous drainage, right down to the implant. I just filleted the ankle open, debrided everything, removed everything that was non-viable, took out the implant, injected this antibiotic synthetic bone void filler in there, put her in a frame, packed about 10 to 12 millimeters of matroderm. I just kept packing that until we got to the level of the skin. I didn't care if 50% filled in, so be it. We'll go back, we'll do it again. Over time, the tissue started to fill in. We started getting coverage of that anterior tibial tendon, which I did not take out. I just debrided it significantly with the Versajet until I got the healthy tissue. And then we got to the level where the tissue was at the level of the skin. So for me, again, I'm pretty aggressive. I don't need a healed skin envelope to do my osseous reconstruction. The wound's healed, the wound's clean, there's no gross infection, the patient's on long-term antibiotics. We have that synthetic bone void filler that's eluting antibiotics into the bone and the tissues. So we're just gonna go and keep moving forward. And so we're gonna use this PEC 3D implant, which is polyether ketone. It's got the same elastic modulus as cortical bone. It's bacteriostatic, which is perfect indication for this type of procedure. I designed it as a lattice structure. It's for an intramedullary nail. There's an additional 5 millimeter screw hole for it. If I really get stuck, I've got holes in the talus component where I can do TN fixation. You can design these however you want. And for me, I designed the sizers with temporary fixation so that I can ream the canal with the sizer, and I don't have to worry about ruining the implant itself. And so this is preparing For the fusion with the sizer, this is us putting that extra 5-hole screw, which is designed to avoid the nail, which is pretty remarkable. And because we removed so much bone, I was able to kind of close some of that anterior ankle wound some more and get it more closed. Not all the way, but more. Intraoperative photos, post-op. This is the patient around March 6th. As we can see, that anterior ankle wound is almost completely healed. And then the patient was healed around May 8th, walking in shoe around May 8th. For these 3D implants, I've done about 5 now. I'm walking them in 2 months in a boot. They're not breaking down. They're all neuropathics that are not having a lot of pain. The structural integrity of the implant can withstand the bone. It's not as hard and dense as metal, so it's not going to cause subsidence of the bone, especially in patients with diseased bone or comorbidities where the bone physiology is not ideal. And so we didn't have to do a muscle flap. We didn't have to do any type of advanced soft tissue reconstruction. We just used Matroderm to kind of fill up that anterior ankle wound and got her completely closed. And now she's walking in a shoe. And we took a very complex issue and we're able to salvage this. That's all I have. Any questions? Yes. Sure. I could. In some of the cases I have. Honestly, I just rely on the neurovascular studies. If I have any questions, then I'll have vascular take them for an angiogram or do a CTA. But in these cases, one of the cases already had the angiogram done, so I knew what I was working with. The other patient had completely normal vascular studies, so I didn't feel like an angiogram was indicated.
Yeah.
Yeah, so for the first case where I didn't initially skin graft on the donor site, I put Matroderm on there and just wound backed it. And then I just let it fill in. And then when I came back and skin grafted, I did do another Matroderm over that as well. I just feel like it makes the skin heal better, personally. I do. I mean, and that's just my experience. Everybody has different experiences and different outcomes, but I've seen them enough break down. I was like, I'm just going to wait until the wound looks 1,000% improved for me to do a skin graft. Other questions? All right, great. Thanks for having me.
Thank you, Doctor.
No problem.
We have about 30 work or just have another Tilton food back in the Dakota room. Start with our second keynote.